today we will do liver, gallbladder, biliary tree, pancreas, portal hypertension, and some general surgery, depending on how much time, how much energy, how well energized you are today. To start with liver, now the thing about hepatobiliary is it's very poorly understood. It is a little difficult, but I'll tell you, even when I was an MBBS student, मेरे को भी hepatobiliary काफी tough लगता था. So it took me a lot of time to understand it, teach it, and simplify it. So what I'm going to teach you is the most simplified way of learning hepatobiliary, which I myself took time to develop. So I can understand that it's a little tricky topic. Okay, so I will simplify it for you as much as possible. So if you see my videos of 3-4 years back when I was teaching on an academy, इतने easy नहीं थे तभी भी. So over the years, it has become easier for me to explain. It's one of those topics. तो हर कोई आपको ये easily नहीं सिखा सकेगा. मुझे भी बहुत टाइम लगा. So first thing is liver. Liver, you know, is one of the largest glands in the body. It has many functions. It will detoxify your blood. So when you enjoy your weekend, all the smoking spirit spices that we did in the last 2 sessions, liver will detoxify it. It will also produce proteins. It will produce clotting factors. It will produce bilirubin. All those things liver is going to do. What does a surgeon need to know? Surgery के लिए क्या जरूरी है? तो सबसे पहले little bit about anatomy. So if you see where the liver is, okay, it's a very big organ in the abdomen, and most of the liver lies just below the diaphragm. So you have the diaphragm, there is a right dome of diaphragm, there is a left dome of diaphragm. Most of the liver lies below the right dome of the diaphragm. Most of it. Little part is on the left also. This liver is going to be divided into two halves. ये सबसे important है. So there is an imaginary line which divides the liver into two halves. What is this line? Cantley nahi, Cantley's line. Okay, it is called Cantley's line. So this Cantley's line is an imaginary line. It divides the liver into right and left lobes. Right and left surgical lobes. So surgical division is by this. Where is this line? How do I really imagine it? Where does it actually lie? एक वाइन आती है शैंटली वाइन, काफी फेमस है, नासिक में मिलती है. इफ यू नो व्हाट इज नासिक, इट्स अ नासिक की विनयार्ड. सो शैंटली का एच निकाल दो, कैंटली. So this line passes through two structures. One structure, of course, is your gallbladder, which lies somewhere like this, and the other structure is something behind the liver. That is the IVC. So the line passes through IVC, gallbladder fossa, and there is one more structure I am not showing in the image. That is the middle hepatic vein. That is the location of the line. Now you will be like, okay, who was this Cantley? Why did he make this line? What is the purpose of this division? ठीक है ना? Okay, left, right. It's anyways a very big organ. Why are we really dividing the liver like this? What is the benefit of this division? Kidney को तो हम नहीं divide करते. Kidney, pancreas, stomach, we don't divide it. So why are we dividing this? That's because the two halves get their own blood supply. So if you know the blood supply of the liver, so somewhere here there is abdominal aorta, which gives an anterior branch. Yesterday we studied superior mesenteric, inferior mesenteric, but those are the second and third branches. The first branch is the celiac trunk. That is the first branch of abdominal aorta. It gives one artery which goes like this, hepatic artery, common hepatic. This common hepatic artery will divide into left and right. It will go to left lobe, right lobe. So when I say left lobe, right lobe will get left hepatic artery. Right lobe will get right hepatic artery. So one of the dividing reasons is going to be hepatic artery. But do you know how much blood does it supply to the liver? How much does the liver get from the hepatic artery? 2/3. No, not 2/3. It is 1/3. It is about 25 to 30%. Imagine organ getting blood supply only 25-30% from an artery, which is so unusual. On the other hand, most of the blood supply of the liver comes from a vein, very important, very big vein. That is the portal vein. So the portal vein is formed behind the pancreas. You will study this in pancreas portal hypertension. So there are two veins which come together to form the portal vein. Splenic vein, which goes to the spleen, superior mesenteric vein. They will come together, form the portal vein. This portal vein will also divide into two branches. So left half of liver will get left portal vein, right half of liver will get right portal vein. So portal vein also divides the liver into left and right branches. This will be about 65 to 70% of the liver. So the main blood supply of the liver is not an artery, it's a vein. Okay. This portal vein collects all the blood from the intestines, basically. So whatever kachra you eat or drink, it goes into the portal vein from the intestines, right? So that's how it begins. So that's why left half and right half have their own vascular supply. So if I want to remove left half of the liver, all I have to do is ligate the left hepatic artery, left portal vein. Then left half will become ischemic and I can cut it and remove it. Easy. Same way I can do right hepatectomies also. Further, they also have different venous drainage. Like right half of liver will drain via the right hepatic vein. Left half of liver will drain via the left hepatic vein. And there is one extra vein, middle hepatic vein, the one that I was talking about earlier. These three veins will go and join the IVC. Okay, so there are three veins which drain the liver: left hepatic, right hepatic, middle hepatic. Right hepatic from right lobe, left hepatic from left lobe. Are you at Sounds good? Okay, so that's why you are dividing the liver into two halves. It allows me to do left liver resection, right liver resection, keeping one half intact. Okay. Now coming to little one step ahead, liver is further subdivided into segments. They are called as Sphenoids segments. So if you see the left lobe, it has three segments. So the left lobe will have three segments. They are numbered 2, 3, 4. 2, 3, 4. The right lobe has four segments: 5, 6, 7, 8. 5, 6, 7, 8. Where is segment 1? वो कहाँ गया? इसमें दिख नहीं रहा जो. Very good. So there is one segment which is separate. It's not counted in left or right. अलग है वो. That is called segment 1 or the caudate lobe. It is taken separately because it behaves differently. It has its own blood supply, its own venous drainage. So it is taken separately. Okay, it lies behind the liver, right? Okay, someone wanted to see this? From these lobes, so now if they ask you, let's say I am doing left hemihepatectomy, मुझे left liver निकालना है. So when I say left hemihepatectomy, what segments am I going to remove? I will remove segments 2, 3, 4. Similarly, when I'm doing right hemihepatectomy, I'm going to remove segments 5, 6, 7, 8. Okay, ये पता होना चाहिए which segments are removed. Sometimes they ask you, gallbladder lies adjacent to which segment? It is segment 4. Okay, it is segment 4. Actually, it is segment 4B. 4 is further divided, 4A, 4B. So gallbladder lies against segment 4B. Okay, इतना याद रखोगे, बहुत सारी anatomy आ गई इसमें, बहुत आसान हो जाएगा. But this much you should know. I don't know if this will be covered in anatomy or not, but this is a surgical anatomy of the liver that you must know. Second thing that you must know is, how will I come to know if there is damage to the liver, like cirrhosis of liver, viral hepatitis, or any disease where the liver is injured? GIT organs, it's very easy. I can do endoscopy, right? Or I can do stool tests. That's what I did in GIT last 2 sessions. Liver, to understand that it is injured, I do some liver tests, which are called as LFTs. So there are a lot of liver function tests that we do, and they tell me about damage to liver. Now, based on these LFTs, there is one score I can calculate. This is a PYQ. This was asked in FMG. That's called child score. What is the use of the score? Child score का फायदा क्या है? Why do I use it? Child score or child puck score or child poo torcot. Do I use it in viral hepatitis? I got acute viral hepatitis. Do I apply child score there? No. Yes, yes, no. Treatment. Okay. Prognosis. No. So please be very clear. This score I will use only for severity of chronic liver disease. Okay. So it will tell me a severity when the liver is chronically injured. Basically, it is used in cirrhosis. It is not used in acute viral hepatitis. Okay. If I want to know magnitude of injury, how badly the liver is injured because of cirrhosis, I will use child score. And how do I use the child score? There are those 5 things that I check. जो बच्चा पढ़ता है, what does the child read? A, B, C, D, E. So there are those 5 components that I measure. This was asked in the exam, where A stands for albumin, B stands for bilirubin, C stands for coagulation. Okay, it is not creatinine, it is coagulation. How do you measure coagulation? Prothrombin time or INR, PT-INR. So coagulation profile will have PT or INR, prothrombin time or INR, international normalized ratio. T stands for distension. Distension, why do you get? You get because of ascites. And E is encephalopathy. So these are the 5 things that I measure. And each of this is given a score from 1 to 3. Everything is given a point, 1 point to 3 points. So maximum score that I can get will be 3 in each, maximum will be 15, minimum will be 1 in each, that will be 5. Understand, higher the score, more severe is the chronic liver disease. This is what you need to know. Higher the score means if my score is 5 or 6 by 15, good. If it is 7, 8, 9, moderate. 10 or more, severe. Someone who has a child score of 10, 11, 12, 13, that person is what is categorized as child C. That person will require a liver transplant. Okay, you can see the whole score if you want, it's over here. But I don't expect you to remember each of these components. At least you should know what are the parameters, because that is what was asked. And at least you should know the how much score is possible. इतना पता होना चाहिए ये part. ये नहीं याद रहा, if you can't remember, and if this comes in the exam, it's okay. This is not for children, this is for anybody with cirrhosis. It's a score of cirrhosis. Okay, अभी बच्चों में cirrhosis is not very common. Usually it is seen in adults because of Saturday night, right? So it is a score of cirrhosis. बात खत्म. बच्चा हो, बूढ़ा हो, कुछ भी हो. If you have cirrhosis, you want to know mild, moderate, severe, you use this score. And these are the components. Easy way to remember, A, B, C, D, E. आई बात समझ में? तो अभी चलो इसका आंसर बताओ. ये देख लो, ये लास्ट स्लाइड देख लो, आराम से देख लो, फिर इसका आंसर बताओ. This came in FMG. Easy question. Can we calculate? You can calculate for any cause of cirrhosis, Hep B, Hep C, whatever it is. But a person, you will use it if he has cirrhosis. Right. So what are the components? A, B, C, D, E. So encephalopathy is there. AST is not there. AST is SGOT. It is not a part of the score. Okay. Creatinine is not a part of the score. So albumin, bilirubin, coagulation, distension, encephalopathy, answer is B. Okay. These kind of questions you should get correct. Huh? You should not make mistake in these kind of questions. Only then you will get 30 marks in surgery, and then mission 150 will become an easy reality. So that's how you should think. These are bread and butter questions. These are not difficult questions. Now come to a very important disease. Many times they ask this. They don't ask this only in FMG also. Huh? They ask in NEET PG, INICET, every entrance. They love, for some reason, they have a love-hate relationship with this. And for some reason, students make mistakes. That's why they keep asking it again and again. Easy disease, that is hydatid cyst disease. This disease is a type of what is called as zoonosis. It's a type of zoonosis. You understand what is zoonosis? Maybe microbiome, maybe you were taught. It's not from animal. The organism has the whole life cycle in animals. The whole life cycle of the organism is in animals. Like you cannot say coronavirus is a zoonosis because the whole life cycle is not only in bats. Man is not necessarily a part of hydatid cyst disease. जरूरत नहीं है इसको इंसान में होने की, वो तो हो जाता है कभी कभी. क्यों होता है वही बताएंगे. So since it's a basically disease of animals, you need to know whenever you study any parasite, you need to know the main host, the definitive host. Definitive, DEFI is definitive. And you should know the intermediate host. What does definitive host mean? And what does intermediate host mean? What is the meaning of these words? Who's definitive, who's intermediate? कहाँ से आ रहा है नहीं. The one in which the reproductive phase happens. Yeah, reproductive phase is the definitive host, which is going to be dogs. And the intermediate host is sheep. And the name of the parasite, ये भी उन्होंने पूछा है, पता है एग्जाम में. Name of the parasite is the dog tapeworm. It's a type of a tapeworm parasite, also called as Echinococcus. So the parasitology name is Echinococcus granulosus. That is a parasite. तो अभी इसमें इंसान की क्या गलती है? इंसान कहाँ से आ गया? So man is the accidental host. Man gets it by accident. Should not be getting it. Man is the dead end host. Dead end means if hydatid cyst happens in man, the life cycle of the parasite will end. Because from man, it cannot go back to the dog. At least it should not go back to the dog. So man is the dead end host, unfortunately. Unfortunately for the parasite. So the parasite does not want to come into you. Okay, because he knows if he comes in you, his life cycle will end. तो खुश नहीं है तुम में आके. ऐसा मत सोचना क्यों आ रहा है. गलती से रोएगा वो तुम्हारे अंदर आएगा क्योंकि लाइफ साइकिल खत्म हो गई. इंसान खत्म, लाइफ साइकिल खत्म. So this is the life cycle. Now, how does man get it? The parasite or the larva enters the man echoorally. Okay, so it's not actually coming from the dog. Wherever the dog shits, or sorry, I forgot, poops. I won't use that dangerous word. So in the feces of the dog, the eggs are passed. And if you have contaminated food, which has contaminated with feces of dogs, it will enter your GIT, it will mature, and it will enter your intestine. So it is not really contact with dogs. It is because of contact with dogs poop or feces. Okay, you know what word you like to hear. I won't be saying that ever again. And when it reaches your intestine, it punctures your intestine, enters the portal vein, and from the portal vein, it goes to the liver. That's why it commonly goes to the liver. So liver is the most common site of hydatid cysts in man because it is going from the portal vein. Now, once the parasite, the larva, once they reach the liver, what are they going to do? They are going to form cysts like this. Okay, and this cyst has a very big wall, and inside the wall, it will start producing daughter cysts like this. And inside the daughter cysts, there can be more cysts. So cyst ke andar cyst karke it will start becoming multicystic, and it will have some liquid inside. Because it's a cyst, it has to have some liquid. That liquid will contain the scolysis, which is also called as the hydatid sand. So like this, you will get one or maybe two big hydatid cysts in the liver. Akash, anchovy sauce इसमें नहीं है. There is no anchovy sauce here. This is a cyst. It has a whitish color wall with grayish white liquid. ठीक है, cyst होगी liver में. Is it life threatening? Can it kill me? Okay, I got hydrated cyst. Big deal. The parasite will die over there. PV is portal vein. Is it life threatening? Can it kill me? When burst? Jaundice. Oh, okay, okay. So please understand, what will it do to me? The complications. Obviously, someone wrote correctly. If it ruptures, the cyst can rupture if it becomes very big. If it ruptures, two things can happen. One is it can enter the bloodstream and it can cause anaphylaxis. ये आपको माइक्रोबायोलॉजी में पढ़ाएंगे, बट रियली स्पीकिंग एनाफाइलैक्सिस होता नहीं, but it can cause anaphylaxis. More than that, it can spread to peritoneal cavity, or it can spread to the lungs. So it can spread to peritoneum, or it can spread to the pleura because it has ruptured. And rarely it can cause biliary compression. The bile ducts in the liver can get compressed. So it can cause a biliary compression, but that's very rare. So by itself, cyst will not cause anything by itself. Only if it bursts or starts pushing around, like how you guys get pushy sometimes, then it can cause some problems. But as long as it is sitting quietly in the liver, there is no problem. ठीक है, तब तक सब सुख शांति है. जब तक आप सुख शांति में बैठे हो, मैं सुख शांति से पढ़ाऊंगा. When you start acting pricey, when you start pushing me around, or when you start being explosive, then there is a problem. Then anaphylaxis automatically, right? Yesterday's experience. So stop wasting our time. Yeah. Anyway, so this is not always going to happen. It may happen. The rename. So how will the person present? Usually, someone wrote this correctly. It will be an incidental finding. मतलब आपने अल्ट्रासाउंड कराया किसी कारण से, so it will be seen incidentally on ultrasound many times. Or if the cyst is very big, because it just kept growing, it can present with a lump in abdomen. That is going to be enlarged liver. So when you are going to get a clinical scenario in this, it will usually be either found by chance, or it will be a finding of lump in abdomen, enlarged liver. Liver इतना size में बढ़ जाएगा because of the cyst, it will become palpable. बस और कुछ नहीं होगा. These complications are very drastic. They will be in your face. तो वो normally होते नहीं. So whenever a person presents, basically your scenario will be, person presents with hepatomegaly. How will you investigate? What is the first investigation you do in person with hepatomegaly or liver as well? USG. Okay, don't do USG. See, we have studied full GIT very systematically. So here also we will do it very systematically about everything in liver, gallbladder, bile ducts. ये सब का ना एक ही सिस्टम है जिसे हमने GIT में पढ़ा है. You will always first do liver function test. Okay, means SGOT, SGPT, albumin, bilirubin, वो वाले PT iron वो वाले टेस्ट करेंगे. Obviously in this disease, even if the cyst is very big, liver function test should be normal. There should not be much problem because rest of the liver is working. So LFT should not normally be deranged. It should be okay because cyst is compressing the liver, but बाकी का liver तो काम कर रहा है. So even if you start acting pricey with me, I will still work okay. I will still continue to teach, right? Unless you cross a certain limit. So same way, liver has a very big reserve. So even if there is a very big cyst or a very big tumor, LFTs don't easily get deranged. So I will not easily get deranged unless you cross that limit. Obviously, the cyst will be seen on imaging. So the investigation of choice, now here also there are two answers. Both answers are okay. Either you will see it on USG or on CCT. If in the exam both options are there by chance, go for CT. Okay, but standard textbooks like Bailey will say you both are okay. Both are good enough to diagnose. Both are good enough. So you see these typical findings. Like what do you see in this image? The first one. What do you see here? What is this? very classical. ऐसे दिखा ना दूर से, you can say it is yeah, this is floating membrane sign. And you see it is floating in the liquid. This is called as floating membrane sign or water lily sign. The name itself tells you that the membrane is floating. So you get floating membrane. You can get water lily appearance. What is the next image that you see? ये image क्या है? And what do you see in the image? What is the imaging modality? CECT. लफड़ा कर रहे हो आप लोग CECT बोल के. Whenever you want to say CECT ना, you see these structures over here. This is probably this is abdominal aorta. It should be white for it to be CECT. Liver should look white for it to be CECT, which it is not. This is plain CT. Cysts are seen on plain CT. What you see in the cyst, so obviously this is a cyst in the liver. You see these partitions. This again is very typical of hydrated cyst. So in this CT, you are seeing partitions which are called as multi-septations. If the septae are too many, अगर इसमें बहुत सारे septations आ गए, over time it will happen, ऐसे 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 ऐसे, then it will look like a honeycomb. So other appearance is going to be honeycomb. What test do you not do? Will you never do in a hydrated cyst? Which investigation is contraindicated? Excellent. Biopsy. Wonderful. Why? Why is it contraindicated? Why biopsy is contraindicated? So please never do biopsy. If you puncture the cyst, it will spill. It can spread to the peritoneum, or you can get anaphylaxis. You don't want the cyst to spread. Why is CECT investigation of choice if cyst not visible? Cyst is visible. Who said it is not visible? You can see the cyst. Cyst ही तो है. Anyway, so you diagnose it like this. पहले के ज़माने में they used to do a blood test, allergy test. It was called Cassoni test. Not done anymore, so I'm not going to write anything which is not done. All right. So पहले करते थे, आजकल नहीं करते. Now it is diagnosed on imaging, and on imaging there is a classification. It is called as Kharbi classification. Don't need to know the different levels. Kharbi 1, 2, 3, 4, 5. No need to know that. But yeah, that is a classification system of hydrated cyst. Now how to treat? How will you treat this? Patient has a cyst like this. What is the treatment? इलाज बताइए. Pair. Will I do pair in every patient? Nothing. Conserve, observe, steroids. Okay. Antiviral. This is not a viral disease. I hope that answer came as a joke, not as a real answer. So first things first, I need to know, is the cyst active or is it inactive? This I come to know on imaging. Inactive cyst looks like a calcified cyst. If the cyst is inactive and the person has no complications, he's okay, he's happy, he's shant, then you will do nothing, you will just do surveillance. So small hydrated cyst which is calcified, nothing needs to be done. Okay, patient is going to live peacefully with it. It is never going to rupture if it's calcified. Problem is if the cyst is active. This you come to know on imaging. CT वगैरह में समझ में आ जाता है cyst में activity है या नहीं. अगर active है तो क्या करो? तब तो छोड़ नहीं सकते. Nothing in surgery we have left. If it is active, it has to be stopped. So if it's an active cyst, the first step that you are going to do is you will make the cyst sterile, means kill the parasites. So you are going to give him albendazole. That is the first step. This is not the treatment. This is the first step. First step, you will give albendazole for 3 weeks. After you have given albendazole for 3 weeks, now you have to do one of the two things. Either you will do pair procedure or you will do surgical excision. Okay, दोनों में एक चीज करनी पड़ेगी, या तो pair करोगे या surgical excision करोगे. What is pair I will tell you, but one step at a time. So first be very clear that the treatment is not albendazole. Albendazole is the first step of treatment. because you want the cyst to become sterile. Once it has become sterile, that's when you decide, do I treat it with pair, sui marke, or do I do surgery? This pair is not done by a surgeon, this is done by radiologists. It's a radiological procedure. So pair stands for puncture. They can ask you the full form of pair. So you should know the full form also. Puncture, that is the first one. Aspiration, injection, reaspiration. Okay. Again, I'm saying you should know the full form of pair, and they will change one of the letters. Like instead of puncture, they will put percutaneous. Percutaneous nahi hai. It is not percutaneous. It is puncture. That is given in Bailey. So what is this procedure in simple words? And why am I saying uski surgery nahi hai? This is a radiological procedure. This is my chest wall over here. Okay, this is my chest wall and abdominal wall over here. And let's say I have a cyst over here, hydrated cyst. What the radiologist will do is he will put a big needle into the cyst from the skin with the help of imaging like ultrasound. So ultrasound पे cyst देखेंगे और ultrasound के help से they will pass a needle from the skin, from the muscles into the cyst directly. So first they puncture the cyst. Then they will suck out whatever is inside the cyst, whatever liquid is there. Then they will inject a scolicidal agent. So there will be injection of something to kill the parasites. That is called a scolicidal. Cidal money kill. Scoli is for scolices. So scolicidal means to kill the scolices. So normally what they use is 10% hypertonic saline. That is very commonly used. Or you can use 10 to 20% povidone iodine. You know what is povidone iodine? You may have seen it. You may have used it at home also. Commonly called betadine. So little higher concentration of povidone iodine. So you first puncture it, aspirate the contents, inject the scolicidal agent, and re-aspirate the scolicidal agent. So that will make the cyst from inside absolutely dry. Then the cyst will collapse. Bus. Very easy. No anesthesia, nothing. That is why technically this is going to be the treatment of choice. So आज के ज़माने में pair is the treatment of choice. It will not spill because the moment I am puncturing, I am aspirating it. How will it spill? If I puncture and leave it, then it will spill. So this is the treatment of choice. Only when I can't do pair for some reason, I will do surgery. So what you need to know is when is pair contraindicated. Because when I can't do pair procedure, I will have to send the patient to me for surgical removal. So normally it's not required, but sometimes it is. So when can I not do pair? Common sense will tell you if the cyst is very far away, cyst is here, the needle will not reach. So if the cyst is very deep seated, or if the cyst has many septations, then I cannot puncture every septation. So if it's a multi-septate cyst or a honeycombed cyst, multiple septae, or better answer, honeycomb. मतलब इतने उसमें septations है that I cannot puncture it so many times. Or if the cyst is having communication with bile duct, that is called cystobiliary communication. If any of these things are there, pair is going to be contraindicated, and in this case I will opt for surgical excision. Okay, in this case I will opt for surgical excision. Surgical excision means do laparotomy, see the cyst and remove the full cyst, which is called as pericystectomy. Okay, that is called as pericystectomy, when I'm going to remove the whole cyst from the liver surgically. Right? Why can't we just give albendazole and just kill the parasite, although they were not showing symptoms like inactive? No, because albendazole, you are not sure how much it will penetrate the cyst wall. If it doesn't penetrate, then what? So treatment of choice has to be pair procedure. Active means hepatomegaly. Active is something that you will see on imaging. That the cyst will have some enhancement, few septations. Calcified cyst is inactive. So if I see calcifications, I know it is inactive. Okay. So that is about management of hydrated cyst. It's a very important topic, and they allow asking something or the other from this topic. So this is one of the topics you must know well. Okay. Now come to another favorite topic for entrances, that is going to be amoebic liver abscess. This is also something which technically you study in microbiology. Okay, technically you study in microbiology. That is amoebic liver abscess. So in the liver abscesses are normally of two types. One are called as pyogenic. They are the normal common ones. Pyogenic. These happen because of E. coli infection of the liver or Klebsiella. Okay, they are the, like how you had perineal abscess, something like that. So they are because of proper infection of the liver. Don't worry about marsupialization. Don't worry. It's not done for hydrated cysts. You don't marsupialize it. The other abscess that you see in the liver, which is a little unique, is amoebic liver abscess. And this is caused by a parasite called as entamoeba histolytica. Okay, that is entamoeba histolytica. This is the one you should know. I am sure some of you would have suffered from it also. Either amoebic liver abscess or amoebiasis. Yeah. So, what is this amoebic liver abscess? How does it happen to you? This again, this is only in man. This is not zoonosis. This is a disease which is seen in man. So normally, how does the parasite spread? The parasite, which is called as the trophozoite, that is a trophozoite, that is the reproductive form. They lie in your intestines. Okay, and from your intestines, they release some cysts, and these cysts are passed in your stools. And if someone comes in contact with your stools or you drink contaminated water with these cysts, eco-orally, you will ingest these cysts. These cysts will go into the intestine and they will become trophozoites. Now, when they become trophozoites in the intestine, what do they do? What will these do once they become mature adults in your intestine? They cause inflammation of the colon. They will cause what is called as amoebic colitis. So most of us get this amoebic colitis. Most of us. This may you get those flask-shaped ulcers. In the cecum or in the sigmoid colon, you will get those flask-shaped ulcers. That is this amoebic colitis. In some people who have poor immunity. So if my immunity is poor, so not everybody will get this. Then what will happen is these trophozoites, apart from causing amoebic colitis, they will enter the portal, just like hydrated cyst. Then they will go to liver. And once they reach the liver, they will start destroying the liver. Why do they destroy the liver? Slowly, slowly, slowly. They start eating into the liver tissue. ऐसा क्यों होता है? Increase number, no, not increase number. Bile, bhook, lymph node. No, none of that. No, Preetham has given the answer correctly. They produce a toxin, which is called as histiolysin. This toxin starts destroying the liver slowly, 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 slowly. So once the parasite has entered the liver from the intestine, so intestine to portal vein to liver. Once it reaches the liver, it will start slowly, slowly, slowly eating into the liver parenchyma and destroying it like this and forming a big abscess cavity. This abscess cavity is not going to have only pus. It will have pus, but it will also have RBCs. It will also have dead hepatocytes. All of this mixed together. This looks like this, which is called as anchovy sauce pus. Okay, so why is it anchovy sauce pus of this particular orangish brown color? It's because the toxin has destroyed the liver. So it is a mixture of hepatocytes, WBCs, RBCs all together. That's why anchovy sauce, right? So it's a dead liver tissue mixed with the pus. आई बात समझ में? In pyogenic liver abscess, this does not happen. In pyogenic liver abscess, there is only pus. Here there is pus plus dead liver tissue. That's why it is anchovy sauce. Okay, and this happens slowly, slowly, slowly. It's not very fast. It's a slow process. So person will not be very sick. It will take time for this entire liver destruction to happen. Okay, I was समझ. So this is what really happens. So in a normal person, you get amoebic colitis. But someone who has a poor immunity, the amoebic trophozoites will puncture the mucosa, submucosa, enter the portal vein, go to the liver, and then traumatize the liver also. Okay, simple. Now come to how will the person present? Clinical features and treatment. This part is all easy, very easy. Tough part is already done. This is the easy part of amoebic liver abscess. Chocolatey to nahi hai ye. This is not chocolatey. Okay. How will the person present? Don't say this will be incidental. Left side pain. Left में क्यों होगा? Liver right में होता है. Left में क्यों होगा? So first thing is, patient will have history of dysentery because of amoebic colitis in the past. So he'll have history of blood and mucus in stools, or history of he has traveled to some area where there is amoebiasis. Like India mein you have amoebiasis. So India is endemic. Gautam Nagar in Delhi, a very famous place where all the coaching classes are there. There you will get amoebiasis whenever you eat anything. So person will have history of this, and maybe few weeks later, now he comes with pain in right upper quadrant. Now the liver is getting inflamed, it is getting purulent. He has pain in right upper quadrant. He has some fever over a period of time, and he has a tender hepatomegaly. So the liver will be enlarged. There will be a tender hepatomegaly. Right. So this is a very typical natural history of how the person will present. Tender hepatomegaly. So when you will palpate, it will be, you will have a little bit of fever, not very high fever. When you are going to examine, the liver will be enlarged. What will you do next? How will you investigate? Now you will use your common sense, I hope. Stool test for cyst. No, don't start with stool test. If he is having tender hepatomegaly, first do LFT. And here, the LFT may be deranged because it is destroying the liver slowly, slowly, slowly. It is inflaming the liver. So the LFTs here may be deranged if the abscess is very big, because your abscess can become very big. So you may have a derangement of LFTs. And of course, to confirm your diagnosis, you will do imaging. And on imaging, again, here you can do USG or CCT. But you should do diagnostic aspiration. So on imaging, you will see the abscess cavity. And when you put a needle and aspirate it, you will see this kind of a pus. Pus, you know, this is going to be amoebic liver abscess. If I culture the pus, what will grow? What will grow in the culture of the pus? Will the amoebiasis grow? So amoebiasis will not grow because you need special culture media. So nothing will grow. So what do you also call this pus? Apart from it being anchovy sauce, what other feature will be seen in the pus? Yeah, it will appear to be a sterile pus. Sterile means no organism is growing. So it is a sterile anchovy sauce pus. That is the hallmark of amoebic liver abscess. Okay, simple so far. Then you go to treatment. How are you going to treat it? What is the treatment of choice for amoebic liver abscess? Medical, surgical, pair procedure, metronidazole. So I am happy many of you are giving the correct answer. For a change, the treatment of choice is going to be medical. Okay. Last month on my Instagram, I had posted a reel on this amoebic liver abscess. एक महीना हो गया almost. उसमें मैंने ये डिस्कस किया. So treatment of choice is medical, and what medicine will you give? You will give double dose metronidazole. Okay, that is the treatment of choice. And for the cysts, you will give diloxanide furoate. So if everything is going to be medical, why the hell do I have to teach you this? क्यों पढ़ा रहा हूं मैं ये फिर, अगर ये मेडिकल डिजीज है? सर को क्या शौक है? इनफैक्ट हेपेटोबिलियरी ना इज मेनली मेडिकल, सर्जरी का काम आता ही नहीं, बिकॉज if it's benign disease, it is medical. If it's a cancer, it's too late to operate, unfortunately. So the role of surgery is very limited. Surgery is only done, as you are correctly saying, if there are complications, like the abscess has ruptured, then you will have to do surgery. Or if the abscess is very large, means it is at risk of rupture, more than 5 centimeters. Or it is a subcapsular abscess, मतलब एकदम surface पे आ गया, अभी लगता है फूट जाएगा. Subcapsular abscess. These are the ones which are at risk of rupture. Only in this case, you may have to do a drainage of the pus. Okay, so this is one of the few abscesses in general surgery where the treatment is medical. I was समझ में? Whatever abscess you study in surgery, like yesterday we did perineal abscess, treatment is incision and drainage. This is one of the few abscesses in surgery which the treatment is non-surgical. The treatment is medical. What is the reason? Why surgery is not required here? So अभी इतना बता दिया, वो भी बता दो. Excellent, because it is a sterile pus. So the person will not easily get septicemia. So septicemia nahi hoga because the organisms are not really there. There are very few organisms. So it will not cause much of septicemia compared to perineal abscess, pyogenic liver abscess, breast abscess. They are all going to be septic. So they have to be treated. Right? Any baat samajh mein? Very good. Okay. So that was about liver. Now moving on to something little easier. This I am sure will not burden your mind too much. Some concepts you need to know in this. Other things are quite straightforward. इस पे question तो आते हैं. Why sterile, sir? Organisms are very few. Organisms are very few. Yeah. But even in pyogenic, you don't aspirate. I mean, you don't operate, but you aspirate it, na? Treatment of pyogenic liver abscess is aspiration, not antibiotics. Pyogenic abscess has to be aspirated. Okay. Amoebic need not be aspirated. Okay. So now come to gallstone disease. But before we do gallstone disease, I want to ask this one question of what does bile mean? Because the traditional anatomical physiological teaching is gallbladder stores bile. What is this bile that the gallbladder stores? And what is that got to do with gallstones? Okay, so when I say bile is something that is produced in the liver. So liver will produce bile. It has small biliary canaliculae. So there are very small ducts in the liver in which the bile is released. So liver produces this bile. It's actually golden yellow, it's not green. So it produces this bile which is released in these bile ducts. So this bile will enter the bile ducts continuously all the time, and this bile will go and get stored from time to time. It will go and get stored in the gallbladder like this. So gallbladder is only storing your bile. It is not making anything. What is this bile that it is storing? It's a mixture of a few things. It's a mixture of bile salts, bile pigments, cholesterol, some proteins like lecithin, and all of this is dissolved in water. All right. So when I say bile that the liver is releasing, it has a mixture of all these chote components which are dissolved in a solution. What are bile salts and what are bile pigments? What are these bile salts? What are these bile pigments? होती क्या है ये सब? Biliverdin, taurocholic acid. Okay, okay, fine, fine, fine. Bile salts come down when your cholesterol is broken down. So whatever cholesterol is there, when it breaks down, it becomes bile salts. It keeps the fat dissolved. It's like for dissolving of fat. So you have glycocolate, taurocolate, all these things. Glycocolate, taurocolate, these compounds. Bile pigments, I'm sure you know, when hemoglobin is broken down into heme will become bilirubin, biliverdin. Then those are all bile pigments. Cholesterol comes from your diet. Proteins like lecithin. So when I say bile, it is actually all this. Now, why am I telling you all this? What is the purpose? It's not to check your physiology and biochemistry. Please understand, the gallbladder will store this bile normally. If something in this bile changes, if the bile concentration changes, then the stones will get precipitated. So, if there is some change in this bile that the gallbladder is storing, like bile salts have fallen, cholesterol has increased, pigments have increased, they will cause stones to get crystallized. That is called crystallization theory of stone formation. Okay, so if I have to get gallstones, this bile concentration has to be up and down. If you have studied renal stones, which we will study in the next half of our FMG, renal stones are formed in a similar way. Urine concentration changes and you get oxalate stones, phosphate stones. It's because of change in urine. Similarly, gallstones or biliary stones happen because of change in bile. So if you understood this, if you know this part, the risk factors become very easy. Okay, risk factors become very easy. So who will get gallstones? You know, बचपन में आपको पढ़ाया होगा fat fertile female of 40. क्यों बोलते हैं वो? आप समझिएगा. It's because, let's take the easy one. If cholesterol increases, if there is too much cholesterol in the bile, then it will form cholesterol stones. So one of the risk factors is cholesterol. Now, why will cholesterol increase if the person has dyslipidemia? So this is one of the risk factors. That's why fat fertile female of 40, dyslipidemia, obesity, high fat diet will cause gallstones, which most of us are having nowadays. So many of us are obese. So we are at risk of cholesterol stones. ये हो गया एक part. Other part is cholesterol is kept dissolved by bile salts. Bile salts keep it dissolved. They form those micelles. If bile salts will reduce, then also you will get stones. So if the bile salts reduce, why will bile salts reduce? ये क्या बात होगी? Bile salt कैसे कम हो जाएंगे? Yeah. Why will bile salts reduce? Ileum. Bile gets absorbed or bile salts get absorbed in the ileum. So whenever there is ileal surgeries, any surgery where ileum was resected, or if the person has short bowel syndrome, or in people who do crash dieting. You know what is crash diet? Like a keto diet. Like I want to lose weight for my marriage. So for 2 months before my marriage, I will give up everything calorie, all calories. I will give up. So such kind of crash dieting where you lose a lot of weight suddenly will give you bile salts will reduce or any cause of rapid weight loss, bariatric surgery. So many of my patients after surgery are at risk of gallstones. So bariatric surgery, very good. All these here you can add OC pills also. OC pills also increase cholesterol. All of these will increase the risk of cholesterol stones. हो गया तो कोलेस्ट्रॉल स्टोन तो समझ में आ गए क्यों होते हैं. जो दूसरे टाइप के स्टोन होते हैं दोज आर कॉल्ड पिगमेंट स्टोन्स and they will happen because the pigments will increase. This part, like bilirubin will increase. Why will the bile pigments increase? This is also very easy. This will happen when there is going to be hemolytic anemia. So hemolytic anemia, more hemoglobin breakdown, erythropoiesis, or pigments can also increase because of certain infections in the bile duct, like worm infections. They can also cause breakdown of bile pigments in the bile duct. So these are the causes of pigment stones. तो आपको पता चल गया, रीजन भी समझ में आ गए और स्टोन के प्रकार भी समझ में आ गए. They are all based on this. Understanding this fundamental will make your life very easy on topics like these. If you try to rectify the causes of gallstones, the types of gallstones, you will forget it in less than 2 days. MCQ solve करना तो भूल जाओ, याद भी नहीं रहेगा पूरा. It will become chaotic, confused. OCPs थे क्या? Short bowel syndrome था क्या? Bariatric surgery, was it gallstones, renal stones? Full confusion. Let that not happen. These kind of things you can understand and replicate quite well if you have spent a little time to get the concept, right? So cholesterol stones will happen when the cholesterol will increase or bile salts will decrease. Pigment stones will happen when the pigments will increase, like hemolytic anemia infection. Simple. So when I say types of stones, there are two types of stones. One are called cholesterol stones, which contain more or less cholesterol, or mixed stones. These are the most common type of stones in the world. Worldwide, they are the most common. Simple reason, because people do have a lot of obesity, dyslipidemia, crash dieting. ये तो सभी लोग करते हैं. So worldwide, they are the common stones. But in Asia, pigment stones are more common. So if they ask you most common stone in India or in Asia, it will be pigment. Okay, so this is a different in the MCQ. Cholesterol stones are radiolucent, means they are not seen on X-ray, because cholesterol is not seen on X-ray. Pigment stones are radio opaque. Anybody can tell why? Why are they radio opaque? Why are they radio opaque? Pigment stones means why are they seen on X-ray? Because they contain calcium. So they are radio opaque due to calcium. These stones are made of calcium bilirubinate, calcium palmitate. They are made of calcium compound. Like bone is seen on X-ray na, because it contains calcium. These stones also contain calcium. That's why they are seen on X-ray. But cholesterol stones are not seen. Right? Cholesterol stones are not seen. Right? So these are the types of stones. ये part तो थोड़ा conceptual था. आगे का part थोड़ा methodical. What is the biggest problem if I have gallstones? You know, because ठीक है, gallbladder में चुपचाप stone बैठा है. Like how some of you are sitting in class chupchap. What's the big deal? So there is a stone over here in the gallbladder. It's not going to do anything, right? Harmlessly sitting there, listening to my class. यहाँ पे बैठा हुआ है एक stone. क्या ही कर लेगा? कुछ करना है क्या उसको? कुछ नहीं करेगा. So what is the big deal if I have gallstones? You know, of the 500 of us today, if all of us undergo ultrasound, some of us will be having gallstones. We just don't know about it. Because obesity, dyslipidemia is there in all of us. Alcohol is there in all of you, not me. So, stones no honge. So the thing is, as long as the stone is sitting harmlessly over here, no problem. Problem happens again when the stone starts acting out. Okay, जब वो ज़्यादा मस्ती करने लगेगा ना, तब problem होगी. Like how hydrated cyst was acting out, it was rupturing. Same way. So long as the stone is here, no problem. Once the stone starts moving about, masti karne lagega, the first place where it will do masti is going to be this area. What is this part? Where it has gone? Where it has gone and blocked? No, it's not CVD. This is the cystic duct of the gallbladder. So the first complication that can happen is if the stone goes and blocks the cystic duct. अगर cystic duct में जाके फंस गया, then the bile will also not go. Gallbladder will start getting angry and distended, and this will give rise to acute cholecystitis. gallbladder becomes angry because it is not able to empty. गुस्सा आएगा उसको. So you are going to get acute cholecystitis. This is the most common and the most important complication of gallstone disease. Okay, this is the most common complication and most important complication. So long as the stone is in the gallbladder, everything is quite happy, nice. Once it goes in the cystic duct, problem. So you get cholecystitis. But if the stone still zid pe aake udhar hi baitha raha, it does not move away. It's like, theek hai na, you are angry, big deal. I will continue with my own shit. So then what will happen is the gallbladder will start getting filled with pus. अब इसमें pus आने लगेगा. It gets secondarily infected. That is called as empyema of gallbladder. It's like an abscess of gallbladder because now the bile is stuck, it gets infected. If then also the stone does not move away, फिर भी वो जिद पे बैठा है, हड़ताल किए जा रहा है, then the gallbladder will become ischemic. It will become gangrenous. And finally, it will give up and it will perforate. Okay, so if it does not give up its zid मार के बैठा रहा, gallbladder ही फूट जाएगा eventually. This is one of the pathways of gallstone disease and its complications. Then there are other complications which are a little more threatening compared to this. Even though this sounds quite dangerous, there are things which are even worse. इससे भी ज़्यादा खतरनाक. If the stone is big, it will get stuck, or if the stone is small, it will get stuck. Which stone will get stuck? Big stone or small stone? Obviously big stone. बड़ा stone पास नहीं होगा ना तो फंस जाएगा. जो लोग बहुत आवाज करते हैं ना, वो इतना डैमेज नहीं करते. The ones who are sitting quietly, the ones who are a little mischievous, they are the ones which cause most trouble. Small stones are more troublesome than large stones. And the reason is simple. If there is a small stone and this छोटा सा stone decides, okay, बहुत सुन लिया मैंने आज ये सर्जरी टीचर का, मेरे को और नहीं सुनना. I want him out of here. I want him out of this class. I want him out of cerebellum only. चाहिए नहीं मेरे को ऐसे टीचर. This will always happen with people who are quiet. So if there is a small stone, it will not get stuck in the cystic duct. It will pass the cystic duct. It will enter the common bile duct and get stuck over it. Because common bile duct, higher authority, small stones को भी पकड़ लेंगे. So if the stone goes and sits in the CVD, that is called CVD stone. This is a dangerous one because now the person will get something called as obstructive jaundice. Okay, now the person will get obstructive jaundice. Obstructive jaundice means ऊपर से जो bile आएगी वो यहाँ फंस जाएगी. Stone will not let the bile pass. Now bile will get stuck in the liver and the bile. That is called obstructive jaundice. A big problem. Obstructive jaundice से क्या होता है? If the bile gets stuck, what's the big deal if you get obstructive jaundice? ठीक है ना, bile नहीं जा रही है, क्या फर्क पड़ता है? Hepatomegaly, hepatitis, no, you get a complication which is life-threatening, much more dangerous than any of these complications. If the bile is stuck in the bile ducts, then the bile will get infected. That is called as cholangitis. And cholangitis can kill the person. Cholangitis means now this bile got infected. It is infection of the bile ducts. This bile got infected, it got filled with pus. This is going to be cholangitis. So CVD stone more dangerous than gallstone. So जो छोटे नवाब होते हैं ना, वो ज़्यादा खतरनाक. They are more life-threatening. And if the stone is even smaller, it will not even wait here. It will go एक कदम और आगे. वो यहाँ पे भी नहीं रुकेगा, वो और आगे जाएगा, and it will get stuck over here at the ampulla, and that will give rise to gallstone pancreatitis. So the stone will go and block the bile duct at the ampulla of the pancreas. So you will get gallstone pancreatitis. This again is a life-threatening disease. So these are the most dangerous complications of gallstone disease: cholangitis or CVD stones, gallstone pancreatitis. Cystic duct stone will not be called as acute choledocholitis. No, it is called as acute cholecystitis. Gallbladder and cystic duct is cholecyst. Choledocho is common bile duct. This is choledocho. CVD stone. This is called as choledocholitis. Choledocho. Chole means bile. Docho means duct. Choledocholitis means common bile duct stone. Okay, so that's different. These are the main complications that you need to know about gallstone disease, acute cholecystitis, CVD stone or choledocholitis, and gallstone pancreatitis. ये तीन सबसे important है. There are some more complications, but these are the important ones. There is a rare complication which was asked in FMG once before, that is called Mirizi syndrome. It's not very common. It's not so common. Mirizi syndrome में क्या होता है? The gallstone directly pushes on the common bile duct like this. So let's say there is a very big stone. It is not passing anywhere. Big stone over here. This stone will cause inflammation and it will press the common hepatic duct. So it will cause a common hepatic duct compression. This is called Mirizi syndrome. How will person with Mirizi syndrome present? What will be the presentation of Mirizi syndrome? Because it is compressing the common hepatic duct. Yeah, same as obstructive jaundice. Excellent, excellent answer. So this will also present with obstructive jaundice. So 100 बात की एक बात ये समझ लो, if a person has gallstones and he gets obstructive jaundice, either he has a CVD stone or he has Mirizi syndrome. Either of them. But more commonly it will be CVD stone. CVD stone is far more common than Mirizi syndrome. So you need to remember this. How does gallstone present by itself? How will person present with gallstones? If the stone is sitting quietly in the gallbladder, incidental pain of what? So 80% patients have no symptoms. 80% are asymptomatic. That's why I was telling you, if all of us, all 500 of us undergo ultrasound, some of us will be having gallstones. We just don't know about it. Only 20% people will present with some symptoms. And what are these symptoms? The main symptom that you get is what is called as a biliary colic. That is a pain. You will present with biliary colic. Normally. Kabhi right upper quadrant mein you get sharp pain after eating fatty meals. That is called biliary colic. On the other hand, patient can present with complications. So he can present with acute cholecystitis. That is the most common complication. How will person present with cholecystitis? पता कैसे चलेगा? He has cholecystitis. So this patient, if the gallbladder is inflamed and angry, गुस्सा हो गया वो, गुस्सा आ रहा है उसको, so obviously he will cause irritation. So person will have right upper quadrant pain. He will also have some fever because the gallbladder is inflamed. And there is a typical sign, some of you have said correctly, that is called Murphy's sign. What is Murphy's triad? Anybody remembers? Murphy's triad. किसी को याद है क्या? Yeah. Where did you see Murphy's triad? Thoracic pain. No. Murphy's triad was pain, fever, vomiting in acute appendicitis. Appendicitis. So appendicitis, Murphy's triad. Cholecystitis, Murphy's sign. Okay. And I will tell you, these two are the commonest diseases a general surgeon will see after hernia. General surgeon क्या करता है? तीन चीज करता है: hernia, gallbladder, appendix. So gallbladder की sign, Murphy's sign. Appendix का triad, Murphy's triad. And these are the two, you will say, bread and butter of a general surgeon. कोई भी general surgeon पकड़ लो ना, वो ये तीन सर्जरी करता है: gallbladder, appendix and hernias. They are the be all and end all, right? So a person will present with Murphy's sign. If he has obstructive jaundice because of CVD stones, then how will he present? If the stone has gone in the bile duct, then how will he present? What does he get? He gets jaundice. Very good. So one thing is he will have jaundice. So any patient with gallstones, if he gets jaundice, you should be worried. That means stone has slipped. So he'll have jaundice. He will have pruritus. Pruritus means he will have itching. He will have clay-colored stools. And he will have dark-colored urine. These are called the typical features of obstructive jaundice. So gallstones, biliary colic. Cholecystitis, pain, fever, tenderness. Obstructive jaundice, pruritus. So this is how normally person with gallstone will present, if at all. But 80% people, no symptoms. How will you diagnose and how will you treat? Asymptomatic people will be diagnosed by chance. Symptomatic people, what will you do first? So please remember, don't straight away jump to ultrasound. When you are going to investigate in hepatobiliary, first you will do LFT. Why are you doing LFT? You should say, na sir, gallstone to देखने हैं, LFT क्यों करूं? क्या मिलेगा LFT से? LFT will be deranged or what in gallstones? बिलीरुबिन क्यों देखना है मुझे? Gallstone में increase होगा? No, so LFT will be normal if it is deranged. If it is deranged. And what derangement? If there is increased alkaline phosphatase or there is increase in direct bilirubin. That means person is having obstructive jaundice. Okay, so if they give you a scenario where it sounds like gallstones, but LFT is deranged, you will think of obstructive jaundice. You will think of CVD stone or Mersey syndrome. Okay, be very clear about this. These are the kind of questions which students misunderstand. Okay, they misunderstand. Pancreatic rule out nahi karne ki zarurat hai because that presents very differently. It's very drastic. We will do pancreatitis. It looks like nothing of this sort. It's very grave. बहुत आगे है वो कभी कंफ्यूज नहीं करेगा. Pancreatitis ना, patient will tell you I have pancreatitis. आपको ढूंढना नहीं पड़ेगा. Pancreatitis is a clinical diagnosis. So LFT should be normal unless there is stone which has gone in the common bile duct. And then of course you want to look at the stone. So the investigation of choice in this case is going to be ultrasound. So this is clear, huh? There is no CT here. Ultrasound abdomen. It is the investigation of choice for both gallstones also, because gallstones are going to be seen here. So they look like this. So when you do ultrasound, this is the gallbladder. This looks like a stone, but how do you know for sure that it is a stone? It will cast this shadow. Only stone will cast a shadow. That is called as posterior acoustic shadow. So if you see a lesion like this, which is casting a shadow, you will say, yes, it is a gallstone. Why do I need to see the shadow? Can this be anything else which has been marked? ठीक है ना, stone ही होगा और क्या होगा? Yeah, it can be a polyp. Polyp will not cast a shadow because polyp is soft tissue. So उसकी shadow नहीं बनेगी. Tumor है, it is soft tissue. Tumor की shadow नहीं बनेगी. Stone only will cast a shadow. ठीक हो गया एक चीज. The other thing that I will see, which is also the investigation of choice on ultrasound only, is there inflammation? So even cholecystitis will be seen on ultrasound. Investigation of choice. Okay, in cholecystitis, I will see that the gallbladder wall is inflamed. So I will see all edema around the gallbladder. That means, yes, he has gallstones also and he has inflammation. So all that will tell me he has cholecystitis. If the LFT is deranged and I'm thinking he has CVD stones, then what should I do? LFT deranged. I think he has CVD stone. Then what should I do? What is the next step? Normally, gallstone, this is enough. But if LFT is deranged and I want to be sure, भैया CVD में stone तो नहीं है, then what should I do? Then the next step is going to be MRCP. Okay, so MRCP, investigation of choice for CVD stone. So there are two MCQs here. Please don't get confused. Gallstone, ultrasound. Cholecystitis, ultrasound. CVD stone, MRCP. Okay, CVD stone is not going to be ultrasound or CT. It will be MRCP. ERCP you will do if MRCP confirms CVD stones. तो अगर MRCP में मिल गया ना stone, so if stones are seen on MRCP, then ERCP. Okay, what I'm trying to tell you is ERCP cannot be done till I know the diagnosis. ERCP only when I am sure. Only when I am sure. If I'm unsure, I will not do ERCP. And you know why? इसका भी एक MCQ आया था अभी वाले FMG में. We will reach it. Today at some stage we will reach that MCQ. Why not ERCP? Okay? इसके ऊपर मैंने एक रील भी बनाया. आप लोग ना मेरे इंस्टाग्राम के अच्छे रील देखते नहीं हो, प्रॉब्लम हो, इसलिए ये सब सवाल आते हैं. All these questions I have already answered them. So ERCP only when I know the diagnosis. Now come to treatment of gallstones. How do you treat gallstones? Surgery. Surgery. सब बोल रहे surgery. Lithotripsy. Normia basket. Sympathetic and asympathetic. Symptomatic. Okay. So the treatment of gallstones is nothing. Okay. You don't have to do anything. You are just going to do surveillance. So then you will be like, just now you were saying gallstones are the bread and butter of a surgeon. All of us, many of us will have gallstones. That doesn't mean we all undergo cholecystectomy. You are going to do cholecystectomy only in certain indications. ठीक है, हम 500 लोग में अगर 50 लोगों को गॉलस्टोन है, सब पीस मेरे पास आके गॉल ब्लैडर मत निकलवाना, ये अपनी गॉल ब्लैडर मत निकलवा लेना. You will do lap chole only in certain indications. They are very easy indications. First indication, you know very well, symptomatic gallstones. Means if the person has biliary colic, obviously you will say निकाल दो gall bladder, कुछ नहीं करना. Or if the person got any complication, तो ये तो हम लास्ट 3 दिन से कर ही रहे हैं. सिम्टोमेटिक डिजीज, कॉम्प्लिकेशंस, लाइक पर्सन हैज सीवीडी स्टोन. सीवीडी स्टोन है तो गॉल ब्लैडर भी निकालना पड़ेगा. और इफ द पर्सन हैड बिलियरी पैनक्रेटाइटिस, मिरीजी सिंड्रोम, कोलेसिस्टाइटिस, ऐसा कुछ भी गड़बड़ हुआ ना, ऑब्वियसली गॉल ब्लैडर निकाल दें. तो दिस इज तो नो रॉकेट साइंस. ये तो अभी बच्चा भी बोल देगा कि हाँ भैया गॉल ब्लैडर में तकलीफ है, उसे निकाल दी. When will you remove gallstones if the person has none of this? So there is a third category where even if it's uncomplicated, no complications, he is asymptomatic, but you will still do cholecystectomy. MCQ comes on this. So they will give you scenarios. They will say all of these are indications for cholecystectomy except. So you should know when will you remove. If you remove gallbladder, what about its function? A gallbladder in someone with gallbladder disease is not functional anyways. Okay, gallstones happen because the gallbladder doesn't function. So when will you remove uncomplicated gallstones? So there are many indications. The important ones are if the stone is very large, more than 3 centimeters, or along with stone, the person also has a gallbladder polyp. So stone with polyp, or person has stone and he has hemolytic anemia, like hereditary spherocytosis, or person has stone and he's about to undergo bariatric surgery. Because bariatric surgery, anyways, the risk of gallstones is very high. Who say he already has stones, so you'll remove the gallbladder beforehand. Or irrespectively, if the person has a calcified gallbladder, that is called a porcelain gallbladder. porcelain gallbladder. That is a calcified gallbladder. It is seen on X-ray. If this is there, this is a pre-malignant condition. Okay, this is a pre-malignant condition. And there are some scenarios where you do concomitant cholecystectomy. Like whenever you're doing any surgery of the biliary tree. So certain biliary surgeries, there is a surgery called as Whipple surgery. In these surgeries, you will remove gallbladder irrespective, concomitantly. Okay, the ones that I want you to remember are the first three. They are the most important ones. MCQ will be except and one of these conditions will change. But please be very clear, अगर कोई भी complication है ना patient को, like CVD stone, or he got biliary pancreatitis, one of the things you have to do is going to be cholecystectomy. Okay, cholecystectomy तो करनी है. Then if the stone is in the CBD also, you will do ERCP to remove the stone, so on and so forth. But cholecystectomy has to be done. A few points that you should know about cholecystectomy that they ask nowadays is this: what is the visualization? Like what should you see when you're doing a cholecystectomy? So I'll just help you here. This is the liver. This is the gallbladder. And this what you see, this duct entering the gallbladder. This is the cystic duct. So this is how it looks actually. And this little thin structure that you see also entering the gallbladder is the cystic artery. So this appearance of artery and duct entering the gallbladder and some liver in the background, you can see all this is liver in the background. This appearance is called critical view of safety. Okay, this is called critical view of safety. Till I don't get a view like this, I will not proceed with cholecystectomy. So this is a mandatory step when you do cholecystectomy. That is called, you should have a view of the critical view of safety. All these three things should be visualized: the duct, the artery, and the liver in the background as separate structures. Now, what is this Callet's triangle? ये कौन सी triangle है? Callet's triangle. कौन सी नई चीज आ गई? I thought many of you will write Callet's triangle. Yeah, some people wrote Callet's triangle. BBB लिखा है लोगों ने. What is this Callet's triangle? सुना है क्या कभी? So Callet's triangle is the area where you do this surgery. It looks like this. You should know the boundaries of Callet's triangle. So this is the gallbladder cystic duct. This is the common hepatic duct. CHD, common hepatic duct. This is CD, cystic duct. And the artery on top over here, cystic artery. These three together form what is called as Callet's triangle. So this triangle that you see here, formed by these three structures, this is the Callet's triangle. So exam question will be boundaries of Callet's triangle. So cystic duct laterally, common hepatic duct medially, cystic artery on top. Okay, now let's come to choledochal cyst. I told you what is the meaning of chole. Chole means bile, voco means duct. So choledochal means bile duct. Cyst means dilation. Simply put, dilation. So choledochal cyst simply means congenital bile duct dilation. So some part of the bile duct is congenitally dilated. So it is a congenitally dilated bile duct. Now bile duct is a very broad, non-specific term. Puri bile duct will not dilate, some parts will dilate. So to identify which type or which part is dilated, there is a classification which they ask in the exams. This is called as Todani classification. Okay, this is called as Todani classification. So this classification tells you which part of the biliary tree is dilated. So what are these types? I will tell you in easy way. So the first type is when the bile duct or the CBD, common bile duct, has a fusiform dilation. Fusiform means like an aneurysm. Aneurysm is fusiform vessel. So it will look like this. So if the liver is over here, this is the left duct, this is the right duct, this is the common hepatic duct. Then you have the gallbladder. This is the common bile duct, CBD. Normally it looks like this. In a choledochal cyst, some part of the CBD is going to be dilated, but it will be a fusiform. Fusiform means SA. It will be a fusiform dilation. So this fusiform dilation of CBD is type 1 choledochal cyst. This is the most common type, fusiform. That is why it is type 1. In type 2, the CBD will be dilated, but it will not be as a fusiform, just one part. There will be an outpouching. You know what is outpouching? Your favorite word from the first session, outpouching. But there will be outpouching, diverticulum, absolutely right. So here, there will be a diverticulum of CBD. So it will be dilated like this. The CBD. Type 3 is very unique. Here, the part of the CBD which is dilated is the end part, the part which enters the duodenum. That part dilates. Ekdam end ka. So, in type 3 choledochal cyst, I will show it over here. The intraduodenal CBD is dilated. Like this. So, this is the part the CBD goes into the duodenum over here. And the terminal, this part, is dilated. That is called as choledococele. Choledococele means intraduodenal CBD is dilated. Intraduodenal CBD. Okay, so type 1, type 2, type 3 are all types of focal CBD dilations. They are the easier ones to treat also. Type 4 and type 5 are little difficult. Means they are little, you can say diffuse. So hard to treat, hard to identify, more grave types, more severe types. So you have the 4, in which you have 4A and 4B. In 4A, there is a diffuse dilation of entire biliary tree. Entire means the part which is outside the liver, that is called as extrahepatic, as well as intrahepatic. दोनों तरफ के bile ducts are dilated. It looks like this. This is 4A. You can see intrahepatic bile ducts are dilated. And here extrahepatic bile duct is also dilated. So it's a combined dilation. A for and extrahepatic. In type B, 4B, there is diffuse dilation of only extrahepatic bile ducts. EH means extrahepatic, means only this part is dilated. Intrahepatic ducts are normal. This is going to be 4B. And in type 5, that is going to be diffuse intrahepatic. This is also called as Kerollis disease. Okay, also called as Kerollis disease. This one. Only intrahepatic ducts are dilated. So basically, ये जो हमारे 4A, 4B, 5 है, they are the diffuse types. Diffuse means involving different parts, not just CBD. So these are the 5 types of choledochal cysts that happen, and they are all present at birth or within the first few years of life. Okay, now coming to how will the person present and what should I do if someone has choledochal cyst. So since it is a congenital disease, matlab these cysts are dilated since birth, means these dilations are there since birth. Will it cause any problem? ठीक है ना? There is like an aneurysm. Aneurysm हुआ तो क्या बड़ी बात है? Latika is saying pain, jaundice, mass. Why should all this happen? Is this life threatening? A disease like this, they don't rupture. It's not like an aneurysm. Actually, like an aneurysm, nahi. It will never rupture. So there are 2 problems. The first one is it is pre-malignant. So it can give rise to cancer of the bile ducts, which is called as cholangiocarcinoma. Bile duct cancer, cholangiocarcinoma. Second thing is, because of the dilation, there can be stasis of bile, and because of stasis of bile, the person can get obstructive jaundice. So typically, this disease is seen in a young female. Young, not like you. Young means someone who is 7-8 years old. A young female, usually pediatrician के पास पहुंचते हैं patients, usually 5 to 10 years of age. So these patients land up with the pediatrician. They come with jaundice. कौन सी jaundice? Obstructive jaundice. माने there will be jaundice, pruritus, dark urine, clay-colored stools. There may be pain. There may be a lump. Lump is usually the cyst. If the cyst is very big, you may be able to feel the cyst also sometimes. So this is going to be the typical presentation of choledochal cyst. So before we move further, this is FMG question, June 2022. What type of choledochal cyst is this? Type 1, type 2, type 3, type 4. Okay, so please understand, this is going to be the CBD. And this part is going to be the part which is of the terminal CBD, the end of the CBD. So this is going to be type 3. Type 1 will be dilated here in the main CBD. This is the distal CBD, terminal CBD, intraduodenal. So this is type 3, also called as choledococele. Okay, choledococele. So this is the type. If patient comes with, no, it can't be 4B. Hello, it's not diffuse, na? It's focal. सबसे पहले देखो focal है या diffuse है. If patient comes with this history, what will you do first? So there is a young female, young girl. You want to say girl, okay? Young girl, 6-7 साल की, with obstructive jaundice, with a lump. What will you do first? Yeah, very good. So your first test, first step, first investigation is going to be LFT. What will you see on LFT? Will it be normal? So here you will get picture of obstructive jaundice. Means there will be increased alkaline phosphatase. There will be increased direct bilirubin. So you have an idea. What will be the next step? Next step, very good. Next step will be USG abdomen. It may show the cyst. It may show. It's not the best test. USG is good for gallbladder. It's good for liver, but it's not very good for bile duct. So cyst may be seen. But if you want to be sure it's a choledochal cyst, investigation of choice, of course, will be MRCP. No doubt about it. Investigation of choice, MRCP. Not ERCP. Huh? इसमें ERCP नहीं है. Diagnosis, MRCP. Now come to the treatment. Do I have to treat every choledochal cyst? If yes, then how? जरूरी है treat करना. ERCP से कुछ नहीं होगा. So please understand, as I already told you, this is a pre-malignant condition. So all cysts have to be excised. So the treatment is going to be cyst excision. Okay, this cyst excision is not always possible. कभी-कभी कर सकते हैं. Like you can actually only do it for these, like this type 1 or this type 2 or type 3 can be excised. But these, they are so diffuse. How are you going to excise them? So depending on the type of the cyst, you are going to do the treatment. For type 1 and type 2, the treatment is going to be excision and reconstruction. So you excise the choledochal cyst and you reconstruct. Maybe you do a jejunum to the bile duct, hepaticojejunostem, depending on how much of the bile duct is left. So type 1 and type 2, excision, reconstruction. Type 4 and type 5 are very difficult to treat because they are diffuse. So ideally, in these cases, ideally, you have to do excision. But many times, since it is going into the liver also has to be removed. Ideally, you have to do excision and liver transplant. Okay, So for type 4, type 5 diffuse ones, liver भी निकालना पड़ेगा. So you have to do liver transplant most of the times. For type 3 na, the treatment is very unique because this type 3 choledochal cyst is inside the duodenum. उसको निकालना मुश्किल है, excision करना मुश्किल है. So for type 3, this is the only type where you don't excise the cyst. What you do is ERCP plus cyst deroofing. माने क्या? You cut one of the walls of the cyst so that it starts emptying easily. Someone was asking the marsupialization. It's a bit like marsupialization. So where the cyst is opening, that part you excise so that it becomes easier to drain the cyst. That is called a cyst deroof. So once the cyst is deroof, it will at least jaundice will not happen. At least jaundice nahi hoga. But yeah, cyst will still remain. Risk of cancer will still remain. So you will have to tell the patient कि पूरी cyst हमने नहीं निकाली है, we have removed part of it, so the jaundice will go, but you have to be under checkup so that in future there is a risk of cancer. LT is liver transplant. Okay, so that is about management of choledochal cysts. Type 3 का treatment is going to be you put an endoscope, ERCP, and then just cut a part of the cyst wall so that the cyst starts draining easily. ऐसे होती है देखो. This is the cyst and it is draining into the duodenum like this. So what I do is थोड़ा सा मैं इसको काट दूंगा. With the help of endoscopy, I cut this part. So when I'm going to cut it, the mouth of the cyst will open into the duodenum like this. We did something similar in the esophagus. Very similar. We did something similar in some other type of a cyst. Yeah, in Zenker's, absolutely. Zenker में हमने stapler से किया था. Here you're not doing with stapler. Here you're doing it with endoscopy. So this is going to be deroofing of the cyst so that the cyst drains. In principle, it is the same. It was just like how we did in Zenker's. We did that stapler, na? So it will help the drainage. It will now start emptying. But see, the cyst wall is still there. So this can get cancer. That risk has to be told to the patient. All right, that's fine. Someone was asking any mnemonic to remember the types of the cysts. So there is one mnemonic I can tell you, but say I'm not one for mnemonics. You see one over here, you see one eye over here. So one eye, you see form. You see the number 2 over here, you see 2 eyes over here. Diverticular. So diverticular, 2 eyes in the तो spelling आनी चाहिए उसके लिए. अगर spelling नहीं आती है तो ये mnemonic काम नहीं करेगा. You need to know spelling. तो fusiform में एक eye है तो type 1 fusiform. Type 2, 2 eyes, diverticular. Type 3, if you turn the 3, it looks like an E. There will be 3 E's in this. C. ठीक है, कोलेडोकोसील, लेकिन उसके लिए कोलेडोकोसील की स्पेलिंग आनी चाहिए. तो ये हो गया 1 2 3. 4 and 5 तो इजी है, डिफ्यूज. 4 and 5 तो इजी है, मैंने वो 4A का बता दिया. 4A is intra and extra. A for and. So 4B will be only extra, 5 will be only intra. You got your mnemonic. I hope you are happy. I am not happy to share such mnemonics, but I know you are happy. Exam. What is type 6 choledochal cyst? There is a type 6 also. It is not there in this classification. What is type 6 choledochal cyst? Okay, let's not go there. Otherwise, people will say I waste time. So let's not waste anybody's even 1 minute of time. Answer this question. But there is a type 6 also. It is not a part of Todani classification. वापस mnemonic लिखा उसने. Pneumonia नहीं है रे, mnemonic है. MNE होता है mnemonic. Which one is dangerous? Diffuse are dangerous because there are so many. The risk of cancer is very high. Type 4, type 5 are not very easy to treat. The children don't survive most of the times. Kasare bada. Okay. So lady was incidentally diagnosed with a 0.5 centimeter gallbladder mass. It is immobile, diagnosed as a polyp. she is having no symptoms. What is the next step? So basically, what will you do for asymptomatic polyps? That is what they are asking you. So obviously, asymptomatic polyps can be left alone. So answer is going to be B. But question that will come next time. This came in INI CET. When will you do cholecystectomy in asymptomatic polyps or indications for cholecystectomy? One is if the polyp is a large polyp, more than 1 centimeter. So this is 0.5. If it was 1 centimeter, then the answer would have been surgery. If the polyp is in a senior patient, elderly patient whose age is more than 50 years, or if the polyp is associated with gallstones, means patient has gallstones. ये तो already आपको बता चुका हूँ. Gallstone with polyp, you will do cholecystectomy. So asymptomatic polyps with any of these, you can do cholecystectomy. If this is not there, then you will do like the question was asking, reassure and. All right, that was about polyps. Now coming to our topic, bile duct injury. Actually, this topic they would not have asked in FMG, but I have seen in the last 2 years questions have been coming on this topic. थोड़ा difficult topic है, थोड़ा high level है, but we will simplify it so that once you clear FMG and you are preparing for NEET or INI, if you are, then also you won't have to study this. It should not come in the exam, but last 2 years it is coming. Okay, it is coming. No. Please be clear. Polyp more than 1 centimeter. That was stone more than 3 centimeters. Please don't confuse things and don't confuse others. This is stone more than 3 centimeters. You did cholecystectomy. This is polyp more than 1 centimeter. You are doing cholecystectomy. Okay, so they are not the same. Don't mix up the two numbers. Okay, so bile duct injury is something last 1-2 साल में पूछ रहे हैं, तो आना चाहिए. To understand bile duct injury, you need two things. First is one little concept, and second is some anatomy. तो पहले आपको anatomy समझा how bile duct injury. So I told you in the liver, bile is produced, which will be released in the bile ducts. These bile ducts come out from the liver as two ducts like this. There is a right duct and a left duct. Okay, so this is the right hepatic duct. This is the left hepatic. I'll write over here. Left hepatic duct. This is going to be right hepatic. The two ducts together will come together and form the common hepatic duct. This will receive the gallbladder and the cystic duct. Okay, so gallbladder will be somewhere here. So this will be the gallbladder and the cystic duct, which will become the common bile duct CBD, which goes into the duodenum like this. Now, bile duct injury कब होगी? This will obviously happen during cholecystectomy. So when I am doing cholecystectomy, जो हमने पहले देखा ना, critical view of safety and all that we were seeing. Why did we know that we should see critical view of safety? It's because during cholecystectomy, bile duct can get injured. They realize कुछ गड़बड़ कर दिया, गलत चीज काट दी, then bile duct can get cut. So normally, if I'm doing surgery in this area, what was this area called where I'm doing the surgery? What is this area called where I do the cholecystectomy? Very good, Callett's triangle. So injury will happen when I'm dissecting Callett's triangle. अब Callett's triangle में injure क्या हो सकता? If you open your eyes and see, you will know what can get injured. Everything cannot get injured. So normally when I'm doing surgery in this area, I can injure either the cystic duct or I can injure common hepatic duct or I can injure right hepatic duct. So normally bile duct injury will affect one of these three structures. Normally. It's very difficult to injure left hepatic duct, दूर है. Common bile duct लैप cholecystectomy में इंजर नहीं होनी चाहिए, हो सकती है पर नहीं होनी चाहिए. होने के लिए ये तीन ही होने चाहिए, cystic duct, common hepatic duct, right hepatic. So these are the three structures which can anatomically get injured. Artery तो I will tie. Artery injury is not the problem because we are talking about bile duct injury. Now let's assume cystic duct got cut and I didn't realize it. What will happen? Or if common hepatic duct got cut, I didn't realize it, what will happen later on? Leak, right? So two things can happen. Or bile duct injury can present in two ways. If the duct is injured acutely, means I cut it, acute injury, then the person will get bile leak. Obviously. So whatever duct got cut, bile will start flowing out. It will go into the peritoneal cavity. Person will get peritonitis, like how you had DU perforation, ileal perforation, biliary injury. So he will have peritonitis. On the other hand, कभी कभार क्या होता है ना, I don't cut the duct. I by mistake tie it, or I by mistake clip it. So sometimes, or I burn it. So sometimes there is an injury where the duct is not cut, it is blocked. This will take some time to develop. That is called as chronic bile duct injury. And in chronic injury, there will be no bile leak. There will be bile stricture or biliary stricture. So whatever duct was injured, it will start becoming narrow over a period of time. And as it will become narrow, he will get obstructive jaundice. Bus, this is the only thing you need to understand. That acute bile duct injury will present with bile leak, chronic injury will present with biliary stricture. Bus. Baki ka part is easy. Now, if there is a bile leak, so during cholecystectomy, something was cut by mistake, bile started leaking. How will the person present? Person will present normally within 1 to 2 days after surgery. So 1 to 2 days after 1 to 2 days after lap chole means patient may be in the hospital or he may have just gone home. एक दिन हुआ घर जाके. Patient will have complaints of right upper quadrant pain because bile is leaking. He will also have fever. Any patient after cholecystectomy, if he gets fever, right upper quadrant pain, it means he has bile duct injury. It means he has bile leak. So when he comes with this, what should I do? I will be worried. Boss, something has gone wrong. कुछ तो मैंने गलत काट दिया. There is a post-operative complication. So what should I do? To manage this, the first thing that I'm going to do is, of course, I will admit him, re-admit him rather. I will stabilize him. And I want to confirm that there is a bile leak happening. So I am going to do some imaging because I want to look at this area. That boss, where is the bile leaking from? Is it leaking from cystic duct, common hepatic duct, right hepatic duct? So I want to know where it is leaking from, at least if there is a leak. So I will do ultrasound abdomen. If it doesn't show anything, I can also do CT abdomen. Both of them are okay. So this is my starting point. कि भैया bile leak हो रही है कि नहीं हो रही? If I see that there is a bile leak, there is some bile which is collecting in the area of cholecystectomy. So bile leak, if it is confirmed, then to manage this, I follow a protocol which is called as SNAP protocol. Have you heard of SNAP protocol anywhere? Anywhere else in surgery? I have not taught it, but you may have heard of it somewhere. SNAP protocol. Where? Yes, but where? Yes, where? मेरी marathon class already देख चुके हैं. SNAP protocol is originally made for enterocutaneous fistula. So when intestine is having fistula with abdomen, that's when you follow this protocol. You can use the same over here. So the protocol tells you, first thing you have to do is sepsis control. Sepsis control means where this is leaking, that has to be removed. So to do sepsis control, you have to drain the leak. You're not treating the leak, you are only draining what is leaked. And to drain, you can put a pigtail catheter. You put a pigtail tube drain, it will remove the bile, whatever is leaking. It's not treating the leak, it is just removing the leakage part. So जो भी कचरा गिर रहा है, it is draining it out. This is the first thing. Once you do this, the fever will reduce, the pain will reduce. Then for N, you will give him nutrition. A means now you want to know which duct is exactly leaking. That is called anatomy of leak or anatomical डिलीनिएशन कि भैया कौन सी डक्ट इंजर हुई है, क्योंकि कभी ना कभी तो उसको टाका मारना पड़ेगा, कभी तो बंद करना पड़ेगा. So you do anatomical delineation. For this, you will do MRCP. Okay, you can also do ERCP in some cases. I'll tell you which ones. And after some weeks, you will do a planned repair. This planned repair is going to be done later. This is usually going to be done after 1 to 2 months. When it is leaking, you cannot go and stitch it, because the problem is whatever you stitch will not survive. The stitches will break. So this repair has to be done later, not in the acute setting. Okay, so you are going to follow this protocol. So at any MCQ, at any stage, if they ask you what is the next step, it will be based on this protocol, that if you feel he's having bile leak because he's having pain and fever, admit, stabilize, image. Because imaging will show you, oh, there is some bile which is collected here. Then you drain the bile. After draining the bile, after patient becomes okay, do MRCP or ERCP. And once you know which duct is leaking, you repair it. But the repair will be done later, not in the acute setting. So this is what you need to know basically. If you go one step ahead, all these leaks are given in a classification system. I'll just tell you very briefly. That is this classification, this part. This is called as Strasbourg classification. I'll just tell you the key part because it's big PYQ आ चुका है. Strasbourg, A, B, C, D. These are all types of acute injuries. Where in type A, you can see the leak is coming from here. That is going to be cystic duct leak. This is the most common type, cystic duct. In type C, the leak is coming from here. That is going to be right posterior duct leak. And in type D, it is leaking from here. That is going to be CHD leak. Now you understand why I told you that the leak will happen from these three places only. Either cystic duct, right posterior duct, or common hepatic duct, which reflects in the Strasbourg classification. इतना ही पता होना चाहिए. Type 1, type A, type B, type C. So only in these three types, type A, cystic duct leak, type C, right posterior duct leak, type D, CHD leak. These are the three which are actually leak. जो type B है ना, in this there is no leak. Here the duct is by mistake blocked. So here there is no leak. B for blocked. So इसमें leak नहीं होगा. This will not present early. Early presentation will only be A, C, and D. This is one thing. The second thing you need to know is, if it is cystic duct leak, it's very easy to treat. The treatment is very easy. All you have to do is ERCP and stenting. Because it is leaking from the cystic duct, you just put a stent over here in the cystic duct, in the common bile duct over here. The leak will stop. Easy to treat. These leaks, difficult. This is what will require reconstruction at a later stage. Okay, so cystic duct leak, early, easy, ERCP. गॉल ब्लैडर कर ले, डक कट करना ही पड़ेगा. जब कट करोगे तो टाका भी मारोगे ना. अगर वो टाका खुल गया, if whatever you tied, if it gives away, or you put a clip and the clip slips, then you will get cystic duct leak. It's not that you cut it and leave it ना. जब आर्टरी वार्टरी काटते हो तो बांध के काटते हो. You don't just cut it. Same way, cystic duct is tied and then cut. If the stitch slips, then you get the leak. Okay. So remember, for cystic leak, ERCP is enough. For other leaks, they are difficult. Okay, they require reconstruction at a later date. So this is all that you need to know about acute injury. So ये जो हमारे planned repair है ना, this is for type C and type D. Okay, for type A, ERCP will be the treatment. बस. तो ये था acute leak. Chronic is easy to understand. हमने obstructive jaundice थोड़ा बहुत कर लिया है, उसका एक कदम आगे जाना है. If the person gets a biliary stricture, means the common hepatic duct has become narrow. So what will happen is few months after cholecystectomy, this will not present acutely. Few months after lap chole, patient will come with obstructive jaundice. Obstructive jaundice means after chole he will have jaundice, he will have pruritus and all those things. So any patient after cholecystectomy, if he gets obstructive jaundice after few months, maybe even years, he has a biliary stricture. Okay, फिर क्या करेंगे? To confirm the diagnosis, first you will do LFT, then you will do USG, and to know the anatomy, investigation of choice will be MRCP. So MRCP will tell you which part of which duct is narrow. Okay, which part of which duct is narrow. You see that, and then you will do the reconstruction. आई बात समझ में? So chronic bile duct injury has to be managed by reconstruction. Wherever there is the narrowing, uske aspas you cut anastomose, put jejunum, whatever is the reconstruction, not important, but reconstruction will be required. Okay, why not ERCP and stent? Nitya, because ERCP and stent is not a permanent treatment. It's not a permanent treatment, because when you put a stent will survive for 6 weeks, 8 weeks, then the stent has to be removed. You cannot keep it forever. This is not angioplasty wala stent. These are biliary stents. Biliary stents are not forever. So what will happen when you remove the stent? The stricture will come back. So stricture can only be treated by reconstruction. You can do dilation of the stricture, but you cannot do stenting. Stenting is not a permanent solution. Stent type 1, 2 months के बाद ही नहीं. Stenting can be done immediately. So for type 1, if it's type 1 injury, then you will do ERCP with stenting immediately. क्योंकि उसमें सर्जरी नहीं है ना, तो there you don't have to wait. Stitch which नहीं करना, reconstruction बाद में करना, because it's a complicated surgery. ERCP is not. क्योंकि the leak will stop after some time. When I put the stent here, once the stent is there, यहाँ से जो लीक हो रहा है ना, थोड़े टाइम के बाद बंद भी हो जाएगा, हमेशा के लिए नहीं लीक होगा. 10-20 दिन 25 दिन में the leak stops, then you can remove this. It's a good legitimate question, but it's not forever. The leak will not be forever. Why stent is not permanent? आप अगर फैमिली में किसी की एंजियोप्लास्टी हुई है उनको पूछ लो. Angioplasty stent is also not permanent. They also get blocked. All stents get blocked because it's an artificial device. So your body will try to. Don't worry about type B. Type B will be treated like this. Type B will be treated like this. So don't worry about it. Okay. Answer this question. चलो. इतना मैंने सब पढ़ाया क्योंकि ये सब क्वेश्चन आ चुके. There are 2 questions of this kind which have come. Yeah. So patient underwent lap chole, he was discharged. Later, patient developed severe abdominal pain, tenderness, LFT was normal, leukocyte count was raised, amylase was normal, most likely caused bile leak due to bile duct injury. Okay, now it makes sense because now you know the progression of the disease. Answer this. See, this kind of questions have come. They should not be asking, but they are asking, unfortunately. So, fortunately, now you know the answer. Patient has undergone cholecystectomy few days back. Now he has upper abdominal pain, which means you're thinking of bile leak. MRCP was done, showed that bile was leaking from cystic ducts. What is the type of injury? What is the type of injury? This is Strasbourg type A. So Strasbourg type A, you can do ERCP and stenting. Okay. Fine. So obstructive jaundice, lot of things I already told you. So few things I will tell you because someone was asking how to decide ERCP, MRCP. वो वाला part बताऊँ. ERCP, MRCP part. Obstructive jaundice happens when there is a block anywhere in the biliary tree. So biliary tree में कहीं block होगा, you will get obstructive jaundice. Like one of the example was this that we just did, this one, where the bile duct became narrow because of a bile duct injury. So obstructive jaundice will happen when the bile duct is narrow. So why does the bile duct get narrow or get blocked? What is the most common cause of obstructive jaundice? सबसे commonly क्यों होगा किसी को obstructive jaundice? Very good, CBD stone. The CBD stone coming from gallbladder. Apart from this, bile duct injury. Any other cause of obstructive jaundice that you know? The bile duct will be blocked. Choledochal cyst, excellent answer. Choledochal cyst, very good. See, now you guys are using your brains. I can assure you that the answers that you are giving are not answers a normal student can give. Okay, these are not easy topics. They take hell of a lot of time to understand, let alone answer. Answer तो दूर की बात है, समझ में ही नहीं आता. And then you can get it because of periampullary tumors. Some cancers can block the bile duct. Okay, so there are many of these causes. Clinical features I already told you that patient will get jaundice, he will have pruritus, he will have clay stools, he will have dark urine. This is what you see in obstructive jaundice. How are you going to investigate? This also we have done briefly. How will you investigate? सबसे पहले you are going to do LFT. LFT will show increase in alkaline phosphatase, marker of biliary obstruction, increase in direct bilirubin. You will do USG. Now the thing is, USG will not tell you the cause of obstructive jaundice, right? It will not give you the answer always. USG may tell you some things, like it will tell you bile duct is dilated. Okay, it will tell you bile duct is dilated. Anywhere, it can be common bile duct or higher up. It will tell you some dilation. Most of the times, the next step, most of the times is going to be MRCP. Okay, most of the times it is going to be MRCP. So then when do I do ERCP? ERCP come. ERCP I will do only when I know the site or the reason of obstruction. Only when I know the cause of obstruction, and ERCP is going to help me with the treatment. For example, only when I know there are CBD stones seen, then I will do ERCP. Or when I know it is a cystic duct injury, cystic leak, type A. In scenario mein, I will do ERCP. Or if the person is having cholangitis, I will do ERCP. आई बात समझ में? So ERCP will only be done where MRCP or CT scan or something told me what is wrong in the biliary tree, and ERCP can help me solve the problem. Like I know there are CBD stones. I'm not assuming. Once I know either on ultrasound, CT, MRCP, कुछ तो test करके मुझे पता है that there are stones in the CBD, then I will do ERCP. It's not done on assumption. ठीक है? Assumption से नहीं कर सकते आप ERCP. Okay, so please don't make mistake in this. Okay, answer this. Yeah, answer this. Patient came with pain in right hypochondrium, SGOT, SGPT are normal. ये सब normal है. Bilirubin is 6. 6 means it is high. Alkaline phosphatase, this is borderline high. What is the next step? Obviously, see, even if you didn't know now what's going on, next first step should be ultrasound. It is the first imaging that I will do in hepatobiliary disorders. Okay, whenever there are hepatobiliary disorders, LFT, USG, that is going to be the pathway. No. USG or CCT was in bile duct injury, not anywhere. Bile duct injury में बोला था मैंने यहाँ पर. Okay, you said, I didn't say. You misunderstood. Answer this. Investigation of choice has to be CCD, not in hepatobiliary. So this is Meniere's syndrome, that there are gallstones, there is a stone here in the cystic duct which is compressing the common hepatic duct. What is the treatment of Meniere's syndrome? How do you treat it? It will present with obstructive jaundice, absolutely right. ERCP, stone is in the cystic duct. ERCP से cystic duct का stone थोड़ी निकलेगा. What surgery? Yeah, the treatment is going to be lap cholecystectomy, but that's not the only thing you will do. When I will do lap chole, this duct can open where it is getting compressed. So lap cholecystectomy with CHD or CBD repair. So when I'm going to remove the gallbladder, the place where it is compressing the common hepatic duct, वहां पर injury होती है. That has to be repaired. So that is going to be the treatment. If you just want to remember, lap chole is the treatment. ये treatment बस. अगर ये second part भूल भी गया चलेगा. Lap chole is the treatment of Meniere's syndrome. Okay, no, don't bring Kasai here. Kasai is in pediatrics. It's not over here. Now come to a very interesting disease. Very different from what we have been studying so far. Liver, gallbladder, bile ducts different. Portal hypertension very unique. It's actually again a medical disease. It's not a surgical disease. You will realize surgeon को इसमें कुछ नहीं करना. जो भी करेगा physician, gastroenterologist, radiologist, they are the people who manage this. So technically, portal hypertension is not something surgeon needs to do. Okay. Now, what is portal hypertension and what's the big deal about it? First, we'll give you a little anatomy of portal hypertension. I already told you some part that I have liver over here and the liver is supplied by a portal vein. Portal vein is formed by two veins. So one part comes from the spleen, splenic vein. SV is splenic vein. Then there is another big vein that comes from here, which drains the blood from the intestines, superior mesenteric vein. They come together, they form the portal vein. And start of the day, I told you portal vein will split left and right portal vein. Left will go left lobe, right will go right lobe. This portal vein will drain into the liver. It will supply the liver. It will give most of the blood to the liver. From the liver, blood comes out in the hepatic veins. So the outflow of the liver are the three hepatic veins. So the three hepatic veins will go into the IVC, inferior vena cava. Now, normally the blood that flows in the portal vein, normally ऐसे जाता है, आराम से जाएगा. If for some reason, somewhere in this pathway, there is a block. Let's say, for example, the person has cirrhosis of liver. Best example is cirrhosis. Cirrhosis में क्या होता है ना? In the liver there are nodules, micronodular. So let's say a person has cirrhosis, common cause. अब cirrhosis में क्या होगा? The portal vein branches which are inside the liver, they will get compressed. The nodules, like how in the yesterday you guys were troubling me, it will start pushing on the blood flow. So like how you were breaking my chain of thought yesterday, same way, the nodules will break the flow of blood in the portal veins. So what will happen is, if the blood is not flowing smoothly, the portal vein will get loaded with blood over here. There will be traffic jam. सारा मेरा chain of thought टूट गया, सारा content रह गया. Portal vein gets loaded with blood. It will start dilating. बढ़ते जाएगा. These branches will start dilating because blood is not flowing smoothly. So the vein will start dilating. Proximally, traffic jam, traffic jam, traffic jam, traffic jam. Whenever there is traffic jam, pressure is high, gussa is zyada. So the portal vein becomes hypertensive. So what is portal hypertension? It's a traffic jam of blood in the portal vein leading to high pressure. How high pressure? The portal pressure or the pressure in the portal vein should be more than 10 mm of Hg. Okay, in a normal person, the flow or the pressure should be less than 10 mm of Hg. To label someone as having portal hypertension, the pressure should be more than 10 mm of Hg. But obviously, this is not a pressure that you can measure. Portal vein तक पहुंचना मुश्किल है. There is a proxy measurement. Anybody knows how do I measure portal pressure? Proxy. मतलब ये तो नहीं नाप सकता मैं. There is something that mimics portal pressure. Doppler, no, not Doppler. You measure something which is called as hepatic venous pressure gradient, HVPG, hepatic venous pressure gradient. This is an important value. It's called HVPG. If it is more than 5 mm of Hg, then also you can say patient has portal hypertension. How it is measured, we don't need to know. Okay, so let's not go there. Why does someone get portal hypertension? Why should the portal pressure increase? Anybody knows? Portal pressure क्यों बढ़ेगा? What is the reason for this portal pressure increasing? Cirrhosis. Okay, so basically anywhere in this tree there should be a block. It can be a block over here. There can be a block in the liver, or there can be a block in the portal vein directly. So there are 3 sites. The first site is in the liver itself. Most commonly it will be because of cirrhosis. Cirrhosis is the most common cause of portal hypertension worldwide. But there can be block in the portal vein directly, that is called prehepatic. Portal vein में block क्यों होगा directly? Why should the portal vein get blocked? Portal vein में cirrhosis नहीं होता. Thrombus. It happens because of portal vein thrombus. क्यों होना चाहिए भाई portal vein में thrombus? Why should this happen? Portal vein thrombosis. Hypercoagulation, like Apla syndrome. Any other? Any surgical cause? DIC में नहीं होगा. कुछ भी मत बोलो. DIC में नहीं होगा. DVT emboli. DVT will not go into the portal vein. DVT will go into the IVC, into the pulmonary veins. But Chiari is hepatic vein. कुछ भी फेंक रहे हो तुम लोग. फेंकू लोगो. No. So portal vein thrombosis, you said correctly. There are some hypercoagulable states, but you didn't give any important ones. The best is going to be pregnancy, occipitals. Then there are some that you study in medicine, like factor V Leiden mutation, antithrombin C deficiency. Oh, wale, ajeeb, Apla syndrome. Someone wrote Apla syndrome. They are hypercoagulable states, or it can happen in the setting of acute pancreatitis. The inflammation of the pancreas can directly cause portal vein thrombosis. Rarely you can get block over here, post-hepatic. That's very rare. So you can get block in the post-hepatic portal circulation. This is called as Budd-Chiari syndrome. All right. So Budd-Chiari is the cause of post-hepatic portal hypertension. Oh my God, yeah. Oh my God. Okay. Yeah. It is there in RR. Portal hypertension is there in RR. It's not only in the main notes. Right? And please someone help the boy who is very hungry. Dinner break. This is like a deja vu of yesterday. I feel I have gone back one day ago. एक दिन पहले चला गया हूँ. जो कल हो रहा था वही आज भी हो रहा है. Deja vu. Anyways, आप लोग आपके दोस्त लोग को ना ट्रेन नहीं करते हो क्लास के लिए. That's the problem. ट्रेन करना चाहिए ना पहले ही. सेम डे सेम स्टोरी. अच्छा, ये कल वाली अंजलि है. अच्छा, दोस्त साथ नहीं है. Anyways, so what you need to understand is either there is a block in the portal vein thrombosis, there is a block in the liver, cirrhosis, or there is Budd Chiari. Budd Chiari may you get thrombosis in the hepatic vein or thrombosis in the IVC. This is also because of hypercoagulable states only, Budd Chiari. So there has to be thrombosis. Basically, somewhere there has to be a block. Wherever there is block, proximal to it, there will be a traffic jam. Okay, so there is a traffic jam. So portal vein pressure is high. So what? कौन सी बड़ी बात है? कौन सी बड़ी बात है? If there is portal hypertension, rupture? No, they don't rupture. अरे पोर्टल वेन थोड़ी फूट सकती है, उसमें बहुत बहुत ताकत है. No, there is no leak. Varice. Why is there varices? Why are there varices? Collaterals. Okay, some nice words are coming. I am happy with the terminologies you are using. So understand what happens when there is a block. I'll give you example of cirrhosis. So let's say person has cirrhosis. And if there is cirrhosis, what is going to happen? So portal vein comes like this. This is the only part that you need to understand in the whole of the disease. Everything else is very easy. If there is cirrhosis, nodularity, then what will happen? Portal vein will start dilating. This will dilate. Everything starts dilating. ठीक है ना? Dilate हो रहा है, जब तक dilate हो रहा है तब तक ठीक है. But a point will come where the portal vein is frustrated. Like how I am also getting frustrated with the same kind of spamming. So a time will come where the portal vein also gets frustrated. Like bus ho gaya. It needs a way out. It needs some outlet. कि अगर blood directly liver में नहीं जा रहा, कहीं ना कहीं तो जाना चाहिए ना. So what it will do is, जैसे I will start cursing you, portal vein also starts throwing abuses at you. It will start throwing what are called as collaterals. So from the portal vein, wherever it is blocked, proximal to it, it will start giving collaterals. And these collaterals will go and join other veins, not a part of this circulation. They will join other veins. For example, some of the branches can go from here, from the portal vein, and they can go to the esophagus. So esophagus ke jo veins hai, they can go and join them. So that now the blood will go into the esophageal veins. Some of the veins from here can go to the renal vein. यहाँ पर kidney होती है. So they can form collaterals with the renal vein. Some of them will form collaterals with the rectal veins and so on and so forth. So what they are doing, they are forming collaterals, other pathways. एक रास्ता बंद हो गया, गलियों से फिर गाड़ियां निकल गई. So the cars are going out from the other lanes into other roads. So they are forming collaterals. So collaterals are actually useful. They are reducing the portal pressure. Right? They are reducing the portal pressure. But some collaterals cause a problem. The most important is this one, the lower esophageal collaterals, which will form the varices, because the varices can rupture. ये सारे collateral का कुछ problem नहीं है. Varices are the problem. Varices फूट सकते हैं. So all these other collaterals are okay, no big deal, no problem. Esophageal varices are the problem. So what you need to understand is where are these collaterals happening? Sites of shunts or collaterals. And what is the effect? The most important are lower esophageal collaterals, which we call as the esophageal varices. So where are they coming from? They are coming from some portal veins, some branches of portal veins, like left gastric vein. This is one of the branches. Left gastric vein, short gastric vein. These are all branches of portal vein. They will go and join esophageal veins like azygous vein, giving you the varices. These are the ones which cause a problem. There are others also. Like there are veins on the paraumbilicus, which are called as caput medusae. But they don't cause any problem. Okay, they are coming directly from portal vein from the left branch. They are coming from left branch of portal vein and they are joining the veins on the abdominal wall. And they give you that caput medusae, which looks like this. So around the umbilicus, you see some dilated veins like this. Caput medusae. But caput medusae कोई problem नहीं देगा patient को. Or you can get veins in the upper rectum. What are they called? Upper rectum. The veins that you get over there, the collaterals in the rectum. SRV. What is the name? No, they are not hemorrhoids. They are called rectal varices. Don't call them hemorrhoids. Hemorrhoids are not in the rectum. Hemorrhoids are in the anal canal. These are in the rectum. So these are called rectal varices. They are coming from superior rectal vein. And they are going to join the inferior rectal vein. So these are the three important collaterals that you need to know, but there are hundreds of such collaterals. Collaterals are required so that the pressure in the portal circulation becomes less. But the esophageal varices, ye wale, they are the ones which can rupture. So normally, when patient comes with portal hypertension, he comes with variceal bleed. Any baat samajh mein? He will not come with anything else. He comes with variceal bleed. Or he comes with cirrhosis. That's why they go hand in hand. Cirrhosis, portal hypertension, variceal bleed. So how will the person present? He presents with this triad of varices in the esophagus. He may have ascites and he may have splenomegaly. Okay, are we clear? So whenever you get this triad, you should know, yes, person is having portal hypertension. If I don't want to measure portal pressure, why not upper stomach? Upper stomach may be hota hai, but it's less common. You get varices in upper stomach also. It is there, but they normally don't rupture. Normally the ones that rupture are lower esophageal. If I don't want to measure portal pressure, how can I diagnose portal hypertension? I don't want to do this HPPG. Is there any way of telling yes, you have portal hypertension? UGI, how? How UGI? Basically, if any of this is present, varices, caput medusae, rectal varices, if any of this is present, person has portal hypertension. Because if any of this is present, that means person is having collaterals. If he has collaterals, he has portal hypertension. Any baat samajh mein? So what I'm trying to tell you is, I don't need to measure any of this to tell he has portal hypertension. I just need to show he has collaterals. If he has collaterals of portal vein, he has portal hypertension. Otherwise, why should he have collaterals? Okay, you can use Doppler, but it's not to confirm portal hypertension. It is for some other reason. Anyway, so normally the person will present with hematemesis. Normally, what are you going to do if he presents with hematemesis? Basic resuscitation. Then we did some of this day before yesterday. So I don't know that he is having variceal bleed. He is only coming with hematemesis. So what am I going to do first? I will stabilize. Means I will do ABC. Then I will put Ryle's tube. To confirm he has hematemesis only. Then I will give him some treatment, basic treatment. Like I will give him IV fluids, PPI, normal treatment. And once he gets stabilized, I will do two things. First is what I did in upper GI bleed for peptic ulcer. I will schedule him for endoscope. But is there anything else I give while I'm preparing him for endoscopy? If I think he has variceal bleed, anything I start in the treatment for variceal bleed? Yeah, I will give him certain drugs which will reduce the portal pressure. Like I can give him, normally what is given is IV terlipressin. This is the preferred drug, terlipressin. Or I can give octreotide. But obviously I will give this only when I feel that yes, he possibly has variceal bleed, because it should not be that he has DU bleed and I give him terlipressin. फायदा नहीं होगा, खाली पैसे waste होंगे. So I stabilize him, I give him terlipressin, octreotide, one of the two, and once he's stable, I take him for endoscopy. Once I do endoscopy, I may see these varices. If I see the varices, I can do one of the two things. I can either do variceal banding or I can do sclerotherapy. दोनों में कोई भी एक चीज कर सकते हैं. Which is preferred? Should you band or should you do sclerotherapy? What is preferred? Sclero. Band, sclero. 1, 2, 2, 1. Okay, banding is preferred. All right, compared to sclerotherapy, banding is preferred because it has a lesser risk of pre-bleed. So the risk of bleeding again is going to be very less. So most of the times, this will be sufficient to treat the patient. Sclerotherapy means the varix that I see, I put a needle inside it and I inject a drug which will cause fibrosis of the varix. That is called sclerotherapy. So I inject some drugs in the varix, like I inject polydocanol. ऐसे होते हैं, which I will inject into the varix, then it will shrink, it will get fibrous. Most of the times this works. If for some reason this fails, or I don't have endoscopy available in emergency, है ही नहीं मेरे पास, I am working in a small center, outskirts of the city, where emergency endoscopy is not possible, it is not there, तो मैं क्या करूंगा? पेशेंट को मरने दूंगा या कुछ करूंगा? In that case, the next step that I do is this. This is called as balloon tamponade. Okay, this is called as balloon tamponade. What balloon is this? Or what tube is this? What is this tube for balloon tamponade? Sangstein Blackmore or Minnesota. Okay. So there are two tubes. I can use any of them. One is called the SB tube, Sangstein Blackmore tube, that has 3 channels, triple lumen. And the other tube is the Minnesota tube, that has 4 channels. Now, what is this balloon tamponade and what are these tubes and how is this helping this variceal bleed problem? Easy to understand. So, stomach is over here like this and the varices are bleeding over here. So what I do is I pass this tube, it's put directly, it's not requiring any endoscopy, directly I can put it. And when I put the tube inside, you can see there are 2 balloons, one is this and one is this. I inflate the 2 balloons. First I inflate the gastric balloon like this and I pull the tube up. So when I pull the tube up, the gastric balloon will come over here. थोड़ा खींचूंगा. And because I am pulling it, the balloon is putting pressure directly on the bleeding varices. If required, I can also inflate the second balloon, the esophageal balloon over here. That will also cause a compression. This compression, physical compression to stop the bleeding is what is called as tamponade. Okay, so tamponade means pressure. How pressure? With the balloon. So balloon is putting pressure. There are 2 balloons, gastric balloon and esophageal balloon. How do I inflate them? In gastric balloon, I put about 300 cc of air. In esophageal balloon, I put about 30 to 40 cc of air, approximately. And I pull them and I inflate them and I tie them so that it gives a little pressure. Now see the tube. In one channel, there is tube which is connected to the esophageal balloon. One channel is attached to the gastric balloon. So दो channel ये हो गए. But also see, there is an aspiration for esophagus and aspiration for stomach. कितने channel हो गए इसमें? How many channels are there? अब बजी घंटी. Yeah, so what is the name of this tube? So this one is Minnesota. What I'm trying to tell you is, if they give an image, don't just jump to Sengstick and Blakemore tube. Okay, please see how many channels are there. If there are 4 channels, it will be Minnesota. If there are 3 channels, it will be SB tube. Okay, they look the same. ऐसे ही दिखते दोनों tubes. सिर्फ ये part अलग है. So your eyes should fall on this to identify which tube it is. Okay, so most of the times, if nothing works, balloon tamponade will work. But the problem with balloon tamponade is it is temporary. It cannot be kept forever. Okay, it cannot be kept forever. This can be kept for limited time. अब ये ट्यूब फुगा के कितने टाइम रखूं मैं? It can be kept only for 24 to 36 hours. उसके बाद I need to do something. Either I do endoscopy or I do something even more advanced. So if nothing works, so balloon tamponade is one step. But if this doesn't work, I have to do something more drastic. And that drastic thing that I do is what is called as TIPSS, TIPS. Okay, it's a very unique thing. बहुत जगह पर नहीं होता है, कहीं कहीं होता है. Very few hospitals have it. How a patient will breathe? The tube is in the esophagus, na? Trachea is open, airway is open. Airway में कुछ नहीं हो रहा. इतना ही inflate किया है that it will compress the esophagus, not the trachea. So patient will breathe. But yeah, the tube is in his mouth or it's in his nose. That's the problem. What 3 point नहीं है ना ये? Okay, चलो. Let's reframe the points. पहले stabilize, फिर endoscopy, फिर balloon tamponade, फिर tips. हो गए? 4 point हो गए? Esophageal spasm होगा, बिल्कुल होगा. But see, the idea is just to keep him alive and stop the bleeding. This is not the final treatment. This is just a temporary treatment. Best treatment is endoscopy only. But where endoscopy didn't do the job, you do this. And where this also doesn't work, you do TIPS. TIPS is a very fancy treatment. बहुत जगह पर नहीं है. TIPS stands for transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt. फैंसी नेम, नाम बड़े दर्शन छोटे, इतनी कोई बड़ी चीज नहीं है, सिंपल ही है, मैं बता दूंगा. But understand how it works. How does this TIPS work? In the liver, you have the hepatic veins going like this, which go into the IVC. Okay, inside the liver, the hepatic veins will have the branches, छोटे-छोटे branches होंगे hepatic vein के. मैंने 2 ही hepatic vein बनाई है, अब 3 होती है. Actually, there are 3. I have shown only 2. Supplying the liver is the portal vein, which will also give many branches. And these branches are dilated now because he has portal hypertension. So all this is full of blood. भरा हुआ है. So they are full of blood. They are throwing collaterals. So person comes with portal hypertension like this. Let's say the block is in the liver and hepatic veins will be collapsed because blood is not going. What I do is I put a catheter from the jugular vein, neck. Jugular vein go down into the heart, into the SVC, Right atrium, IVC. The catheter comes till here in the IVC. Then I turn the catheter into one of the hepatic veins. So all this is going inside the hepatic vein. And once I enter the liver with the catheter, I puncture the liver and connect the hepatic vein to the portal vein. So I went from the neck vein, SVC, right atrium, IVC. I came till here, went into the hepatic vein, went into the liver, punctured the liver, and entered the portal vein. Once I have entered the portal vein, I will put a stent. So here I will stent these two veins. Because I have put the stent, this blood will now go from the portal vein zoop into the hepatic vein. Because it is going into the hepatic vein, now a new road has opened. It's like a bridge. I have built a bridge. Because I have built a bridge, now the traffic jam will reduce. The traffic will be released. And because the traffic is released, the collaterals which were going to the esophagus will also become smaller. They will become less pressurized. So the varices will also collapse and the variceal bleed will stop. आई बात समझ में? So what I have done, I have gone from the internal jugular vein, gone into the liver and put a stent to create a portosystemic shunt. So now the blood will go from the portal vein easily into the hepatic vein. Yes, I am kind of bypassing the liver, no doubt about it. So the portal collaterals will become collapsed. If the portal collaterals become collapsed, the varices will collapse. There will be a collapse of the varices. So it's very good. It will reduce the portal pressure very well. आ गई बात में समझ में? No endoscope is used. This is done by radiologist. It is all done under what is called as fluoroscopy. Like how they do angioplasty, something like that. It's like angioplasty, the same thing. But yeah, do this good then banding. It's not available everywhere. It's not easily available. What is the problem in doing this? दिखने में तो बहुत अच्छा, आप लोग इतने खुश हो गए, sir, why not do this instead of endoscopy? What is the problem with doing this? अगर पोर्टल हाइपरटेंशन नहीं है तो कोलैटरल्स नहीं होंगे. खाली पोर्टल हाइपरटेंशन नहीं करते. There are two problems here. One problem is the stent will take away some of the blood of the liver. So person can get encephalopathy. Okay, person can get encephalopathy. He can have liver failure. And the other problem is more than 50% of the cases, the stent gets blocked within 1 year. So stent gets blocked within 1 year in more than 50% cases. That's why I tell you stent की life होती है. ऐसे मत सोचना स्टेंट डाल दिया तो हमेशा के लिए प्रॉब्लम चलेगी, ऐसा नहीं. Okay, so all stents have a life. Even this stent will have a life. This is all temporary. And of course, if I don't have tips, I don't have a radiologist to do the tips. No tips available. Any tips? क्या करें फिर? What is the last resort? Because अभी तक क्या है? पहले आपने टर्ली प्रेसन दिया, फिर आपने एंडोस्कोपी करी, फिर आपने एसबी ट्यूब डाला, फिर आपने टिप्स करा, सब कुछ किया मेरे बिना, मेरी जरूरत नहीं पड़ी. जब कुछ नहीं काम करा तब मैं आया काम पे. This is what is happening in your life, no? You are coming to learn from me because you must have tried surgery from 10 other places and you're like, मजा नहीं आ रहा, मजा नहीं आ रहा, जम नहीं रहा, too much, too little, too difficult, too easy, no MCQ, no this, no that. So आप मेरे पास इसलिए आए हो ना क्योंकि बाकी सब जगह से थक चुके हो. Hopefully मेरे आगे कुछ नहीं है. Yeah, there is nothing beyond this. People are writing same here. Wow, cruel. So when nothing works, you are going to do surgery. And that surgery is what is called as devascularization. Okay, this is called as surgical devascularization, where you open the abdomen, you see the varices at the esophagus, and you tie them, tie them, tie them, tie them. सब जगह tie कर दो, tie कर दो, इतना बंद हो गई bleeding. है ना? So when nothing will work, you will do devascularization. Okay? So this is how you will manage variceal bleed, but this is not the end of the story. After the bleeding stops, so afterwards, portal hypertension nahi gaya na. You have just treated the varices temporarily, so that he does not bleed again. Again, variceal bleed does not happen. You will put him on lifelong beta blockers. Okay, because beta blockers will reduce the portal hypertension. Normally, what is used is propranolol. Okay, so this propranolol is used for prophylaxis lifelong. ठीक है, आई बात समझ में? Not too bad. So this is a एकदम ऐसा stepwise management. At any stage in this disease, you are going to get some question. Okay, either on some component, etiology, triad of portal hypertension, variceal bleed, management of variceal bleed, drugs that are used. There is a truckload of questions possible in this topic. Can he take this before surgery? He can take it, but it takes time. No, it takes time to act. That's the problem. So there is no benefit of using it. वो आएगा variceal bleed के साथ, right? But yeah, if he's having cirrhosis and he's having collaterals already, then you can start on beta blockers. Fukugawa is one of the types of. It's one of the types of devascularization. One of the types that is called Sugiura Fukugawa. ये सब नहीं पूछेंगे. It's a name. It's one of the types in which you resect the esophagus and do anastomosis and blah blah blah. Forget about it. Yeah, pancreatitis. You will 100% get one or two questions from it on acute pancreatitis. So no running away from this. Again, this is not a disease which really a surgeon manages. It's more a medical disease. You'll realize इसमें surgery का तो barely कुछ role है. So what is acute pancreatitis? Anybody knows? होता क्या है? हम करते क्या है? क्यों होती है? Not the etiology per se, but what happens in acute pancreatitis? And how is it different from chronic pancreatitis? Inflammation. How is it different from chronic pancreatitis? Chronic से क्या होता है? So the main difference is in acute pancreatitis, it is an acute but reversible injury to pancreas. So pancreas gets injured, but it's a reversible inflammation. Largely. So most of the injury that will happen, the pancreas can eventually go back to normal state. In chronic pancreatitis, the injury is irreversible. So whatever changes will happen will remain forever. If I come and बीच में I crack some jokes about you, make some taunts, एक दो चीजें मैं बोलूंगा, और then I go back to teaching. So at that time you will feel it, then you will forget it. But if every second line I am constantly pinning you all the time from start to end, I keep cursing you, saying you are this, you're that, you're this, you're that, again and again and again, then your mentality about me will change. That is chronic. So acute, in between, in spurts, goes back to normal. Chronic, slowly, the injury will keep building up, and whatever changes will be forever. So chronic will be irreversible. We are talking about acute. So acute can kill you very fast, but if your life is saved, then there is no permanent damage. Chronic will kill you slowly. It's a slow death. So why does someone get acute pancreatitis? What are the etiologies? Easy mnemonic here you can use. This is my own mnemonic, that is ABCDE. This is not given in any book. So if you find it in any book, you know where it has come from. A stands for alcohol. And alcohol is the most common cause worldwide. Sorry, alcohol is the second most common cause, not most common, second most common cause. Okay, I thought we were still in the weekend, but it's not alcohol. B stands for biliary pancreatitis. जो हमने पहले पढ़ा, gallstone, small gallstone, naughty gallstone going into the bile duct, going into the ampoule. This is the most common cause worldwide. But yeah, very soon alcohol will become. C stands for calcium. So any scenario where you have hypercalcemia or hyperparathyroidism. Hyperparathyroidism can cause hypercalcemia or hypercholesterolemia. So increased cholesterol can also cause gallstones and it can also cause directly pancreatitis. D stands for drugs. Which drugs you know cause acute pancreatitis? Any drug you know? कोई ड्रग पता है? बहुत सारे हैं. So the important drugs that you should know, one is antiretroviral therapy, then some anti-diabetics, steroids of course, and E, the most important one is ERCP. Okay, ERCP will cause pancreatitis in 1 to 3% patients. This question came in the FMG of Jan 2020, and most students were happy it came, at least the ones who learned from me. Now, what are the types of acute pancreatitis? Most of the times, when the pancreas gets inflamed, there will just be some edema of the pancreas. Means pancreas will swell. That is called as edematous. This is a milder variant of acute pancreatitis. So what will happen is the pancreas, it produces some enzymes. You know, the enzymes which are required for digestion of your proteins and fats. These enzymes sometimes get activated inside the pancreas. They get auto-activated. So if they get activated, they will start causing digestion and inflammation of the pancreas. So it will become edematous. Wherever the enzymes are traumatizing, it will show edema. However, if the pancreatitis doesn't resolve, or if the attack, or if the impact or the injury is very severe, then some part of the pancreas will start becoming ischemic. That is called as necrotizing pancreatitis. This obviously is the irreversible part. So if there is necrosis, that part which is dead is gone. So this is going to lead to either moderate and sometimes even severe pancreatitis. Okay, which means some part of the pancreas has now died. It has become ischemic, it has become necrosed, gone, over. What is dead is gone. It's not going to come back. So basically, edematous pancreatitis come back normal. Necrotizing pancreatitis, whatever is necrosed, it's gone. Okay, these are the types. Now come to the important part, complications. Is pancreatitis life-threatening? If so, then why? Can you die of pancreatitis? Yes. How? Pancreas is inflamed. How is that going to kill me? Sepsis. कहाँ से आ गई sepsis? कौन सी sepsis? Sepsis shock from where? How? Why should there be sepsis? Okay, so let's simplify it. Pancreatitis will give you three types of complications. The first one are called as local complications. Local means they will happen in the vicinity, direct vicinity of pancreas. This is given by a classification which is called modified Atlanta classification. Okay, modified Atlanta classification. So what happens is when there is this inflammation of pancreas, you know, pancreas has those amylase, lipase, those enzymes. Sometimes the enzymes leak out of the pancreas in the vicinity. So there will be some amylase over here, some lipase over here, and they are very powerful enzymes. So what will the peritoneum do? It will try to dilute these enzymes. So whatever enzymes have leaked out, it will have some secretions to dilute it so that it does not cause more inflammation. This amylase lipase mixed with peritoneal fluid, this collection is called as acute fluid collection. So what is this acute fluid collection? It's a collection which is rich in amylase and lipase. It's nothing but some fluid mixed with the enzymes around the pancreas. If for some reason this fluid collection persists for more than 4 weeks, then it will form a wall around it. So what will happen is these fluid collections will start coming together. They will start becoming organized and they will form an inflammatory wall around them. It's not a true cyst. It will have inflammation, wall made of inflammatory tissue around it. This is going to be called as a pseudocyst of pancreas. आई बात समझ में? This is called as pseudocyst of pancreas. कहीं ये सुना है क्या आपने आजकल में कहीं any on anyone's social media you have seen anything of this sort? Yes, no, maybe. Real. Okay, I hope you have. If you haven't, you should. So pseudocyst will happen typically 3-4 weeks, 2 months after pancreatitis. It starts with fluid collection. If the fluid collection will persist, it will get organized, it will form a wall. That will be a pseudocyst of pancreas. It will be seen most commonly in the area around the pancreas, which is called as lesser sac. So this space near the pancreas, that is called as lesser sac. Okay. On the other hand, if the fluid collection has some necrotic material, if this necrotic material goes and leaks, collects with the fluid collection, that is called as acute necrotic collection. So that is called as acute necrotic collection. So basically, it is a fluid collection, AFC, mixed with some necrotic debris. And if this persists for more than 4 weeks, then it will be called as walled off necrosis. Okay, you will call this walled off necrosis, WON. It's not some, आप जीत नहीं गए हो, वो वाला one नहीं है, it's WON, walled off necrosis. These are some complications that you are going to see in the vicinity of pancreas. Yeah? These complications can lead to more complications. So they are the local complications. Apart from this, you can get some complications which are little distant, some distant complications. Like if the inflammation is very powerful, just behind the pancreas, you have a vein, which we discussed earlier, portal vein. So the portal vein can undergo thrombosis. It is just behind the pancreas. Or the injury can extend to splenic artery. You can get a splenic artery pseudoaneurysm. Pseudoaneurysm means it has kind of ruptured. So you can get a splenic artery pseudoaneurysm. Pseudoaneurysm means the splenic artery, which is just behind the pancreas, has gotten ruptured. And then you can get systemic complications. These are important. These will happen when the necrotic pancreas, if there is necrosis and it gets infected. So whenever the necrosis will get infected, what will happen? So let's say there was some necrotizing pancreatitis here. And let's say your E. coli, your favorite friend, got and sat over here and it started forming pus. And you got an infected necrosis. What will happen then to the patient? What will it lead to? Abscess. It's not called abscess anymore, but yeah, it will lead to septicemia. And this is what will kill the patient, septicemia. So whenever you get septicemia, it will affect all your body organs. Like because of septicemia, you can get acute kidney injury, you can get ARDS, you can get paralytic ileus. So एक के बाद एक, your organs will start failing. You can get encephalopathy. So all these are features of septicemia. Any patient with acute pancreatitis, if he starts getting other organ involvement, like his urine output becomes nil, oliguria and urea, or if he starts getting breathing problems, hypoxia, that means he's having septicemia. That means he has infected necrosis. Okay, be very clear about this. So, patient with acute pancreatitis can present in any of these three stages. He can present in the early stage where there is no complication, only edema. He can present with necrosis with some local complications, or he can present with systemic complications. That's how you will come to know what stage of the disease has he come with. So the key word here is septicemia. Now, how does a person normally present in acute pancreatitis? Normally, the presentation will be history of alcohol binge or history of gallstones. Any of these, they are the two important risk factors. And now the person will come with, so like New Year pe bahut sara daru piya, and next day he started getting some problem. What problem will he get? He will get acute epigastric pain radiating to back. It's very classical. I was telling you, before that biliary pancreatitis and all, you don't need to diagnose it. It's a clinical diagnosis. Patient will tell you he has pancreatitis. Many times they know because it's not happened for the first time. So they know it is pancreatitis. So epigastric pain radiating to back. He may have vomiting. When you will palpate his abdomen, he will have a very classical tenderness in the epigastrium. So the tenderness will be there. He will say the pain reduces when he bends forwards. ऐसा history और कोई बीमारी में मिलेगा ही नहीं. Reduction of pain on bending forwards. Very telltale. As the disease gets more advanced, there are some typical signs which happens when there is hemorrhage near the pancreas. They are seen in hemorrhage of pancreas. Like the person gets some bluish discoloration or bruising at umbilicus. So umbilical bruise. I won't write bluish. Bruising at umbilicus. What is that called? It's the PYQ. Yeah, that is called as Cullen sign. So he gets Cullen sign. Cullen sign means there is a peripancreatic bleeding. It's a marker of bleed. It's not a marker of complication. It's a marker of hemorrhage. He can have bruising at flanks. That is called as Gray Turner sign. So ऐसे कुछ findings you can get in addition to these. And of course, if there is any complication, he can present with any organ failure. So he can come with oliguria, anuria, ARDS, encephalopathy, whichever septicemia effects can be there. He can have high grade fever, all those things. Right. So this is how a person can present at any stage. So your lucky question for those who gave the exam, they were happy that this came. Jaundice is not very common in pancreatitis. If there is liver failure, he can get jaundice. So this is ERCP-induced pancreatitis. Answer this. 30-year-old man presented with vomiting, severe pain in epigastrium, radiating to back. This discoloration was seen. What is the diagnosis? And what is the sign? So this is pancreatitis and this is showing Cullen sign. Okay, this is Cullen sign. What do you see? This is the umbilicus. It's just below the umbilicus. Okay? So that is about pancreatitis. Now come to investigations. Patient comes with alcohol binge history with epigastric pain radiating to back. What will you do first? Why does pain reduce on bending forwards? Because the inflammation, you know where pancreas lies, no? Pancreas lies just in front of the vertebra. So if this is L1 vertebra, L2 vertebra, this is the skin on the back. Pancreas lies over here, just in front of the vertebra. And all your retropancreatic nerves are over here. They go like this. So when there is inflammation, it will hit the nerves at the back. So when he bends forward, the inflammation moves forward. Okay, the inflammation moves forward. So it may reduce anyhow. Any patient with a typical history of acute pancreatitis, you need to do only one test, only one blood test. That is going to be serum amylase or serum lipase. Any one of the two you will do. Which one will you do? Or you will do both? Will you do amylase, lipase, or both? Both. Patient will say, Doctor Saab, are you getting a cut from the pathology lab? Are you getting a cut from pathology lab? Depends on time. Okay. So amylase, the thing is, it is very non-specific because amylase can get elevated in anything, any acute abdomen, it can get elevated, but it rises very early to rise. Typically within 6 hours, it will start elevating. On the other hand, lipase is very specific. It is very sensitive also. It's a very good test. But it rises after some time. It rises usually after 12 hours. But yeah, if you have to pick one, go for lipase. होता सबका है, कोई बोलता नहीं. So the investigation of choice, biochemical test, is going to be lipase, not amylase. Go for lipase. When we feel the patient has pancreatitis, we do only lipase. We don't do amylase as practice. Okay. If there are two patients, one patient has a lipase of 500. Okay, normal lipase is less than 200. One patient has lipase 500. Other patient has lipase 5000. Who has a more severe pancreatitis? Whose disease is more severe? With a lipase 500 or 5000? Or it does not matter? Okay. So let's be very clear. The severity does not depend on the levels. Okay. So severity is not associated with the levels. What I'm trying to say is there is no guarantee that someone with a higher lipase or higher amylase has a more severe pancreatitis. It's not like that. Normal lipase can also be severe pancreatitis. It's possible. So they don't reflect the severity of the disease. Okay. Then how do I come to know the severity of the disease? If I want to know severity, is it mild, moderate, severe? Then I will have to do some tests. But before that, any imaging I have to do for diagnosis? What is the role of imaging in acute pancreatitis? USG, CT, X-ray, just CT. So next step here is going to be CT. Okay, so let's be very clear. No imaging is required for diagnosis. No imaging is required. Only if there is a doubt, you will do imaging. Okay, if doubt, like you're not very sure about the disease, you will do CCT. CCT is the investigation of choice. But investigation of choice does not mean I will do it. It means, let's say patient has pancreatitis symptoms, but amylase lipase is normal. Then you will think about doing CT. Or patient did not drink any alcohol, did not have any gallstones, still amylase is elevated, and you are thinking, is it for sure pancreatitis? Then you will do CT. Okay. Otherwise, pancreatitis is a clinical and biochemical diagnosis. No need to do USG, CT, PT, koi zarurat nahi. Okay. So then, is there any actual role of CT? Yes, CT can be used for severity. So whatever tests I do are for severity. So if I want to know how severe it is, one of the ways is CCT. So when should I do CCT? I should do it after 72 hours of symptoms. Not when he comes. When? 3 days or maybe even later after symptoms. So if he says, I started getting pain yesterday and he comes to you today, you will not do CT today. You will do CT after another 2 days, not early. Why should I do it after 72 hours? Because by then the necrosis will be established. If I do it very early enough, I may miss the necrosis. It may underestimate the necrosis. So if I want to see necrosis of pancreas, I should wait for 72 hours. और जल्दी नहीं करना. जल्दी कर दिया, it may show there is no necrosis, but after 2-3 days it may develop. So you do it normally after 72 hours, and CT will give you an index that is called severity index. It gives you a score, and that index tells you the severity of acute pancreatitis. Is it mild? Is it moderate? It is severe. You don't need to know the components of the index. Just know CT से पता चल सकता है. Is it mild, moderate, or severe? Okay. Better than that, there is a classification system which is also called as modified Atlanta classification for severity. You did modified Atlanta once before for pseudocyst of pancreas. You already used it here. This was also Atlanta. The same community, the same group also gave a classification for severity. Like, is he having mild pancreatitis? Is he having moderate pancreatitis? Is he having severe pancreatitis? वो इससे पता लग जाता है. So to say he is having mild pancreatitis, he should have no complications. Only edema, nothing else. To say he has moderate pancreatitis, he should have local complications. Pseudocyst, fluid collection, necrosis, that will be moderate. Or he can have organ failure, means renal failure or ARDS, but the organ failure should last for less than 48 hours. Means within 2 days of treatment, the renal function should become normal. Okay, the renal function should become normal. And to say severe pancreatitis, he should have a organ failure which persists for more than 48 hours. So despite treatment, if his kidneys have still failed, they have not become okay, that means he has severe acute pancreatitis. Right? What if patient comes to hospital at time of necrosis? How do you know there is necrosis? To know necrosis, you have to do CT. So CT will tell you there is necrosis. But necrosis only means that it is maybe mild, could be mild. That means there is local complication. But if there is organ failure, could be severe also. That's why over here I said necrotizing pancreatitis can be moderate also, can be severe also. दोनों चीज बोली. Organ failure हुआ more than 48 hours, severe. These are the two scoring systems you need to know for severity. पहले के जमाने में they used to do one score which was called Ranson score. आजकल नहीं करते. So it's a very elaborate score. You can check it in the notes if you want. आजकल नहीं करते Ranson score. And there is a very simple score which is called BICEP score. Very easy to use. BICEP score. इसमें 5 चीजें देखते हैं. B से BUN. I से impaired GCS. S से SIRS. A से age. And P से pleural effusion. Okay, don't worry about some of these words like SIRS, GCS. GCS we will do when we do trauma. So I'll tell you what is GCS. But these are the components of the score, BICEP score. नाम के अंदर ही सारे components हैं. Which one is important? Of course, this one, modified Atlanta. The most important. ये आपको पता होना चाहिए. That's why I discussed it in detail. Modified Atlanta complications, modified Atlanta for severity. So when the patient comes, he comes with acute abdomen. I check his lipase, it will be elevated. If the symptoms have been there for more than 3 days, I will do CT to see is there necrosis or not. I check his organ failure status. Is there any organ failure? And then I come to know, is he having mild, moderate, or severe acute pancreatitis? On this, I will decide the treatment. Okay, so far so good. यहाँ तक सब समझ में आ रहा है? I hope. यहाँ तक problem नहीं है. Yeah. Okay. Very good. So now come to this question. Okay, this is easy question since you are seeing the context. But more than that, see the way the question has been put. Alcoholic, nausea, vomiting, epigastric pain radiating to back, and this amylase is elevated. Other parameters are normal. So obviously this is going to be acute pancreatitis. Answer this. I don't know if you've heard of this before. This is again something that used to be asked before. आज के ज़माने में नहीं पूछेंगे. Any idea of this? Colon cutoff. So there are some X-ray findings of acute pancreatitis. One of which is this colon cutoff. But these are non-specific, so you cannot rely on them. Colon cutoff, renal halo, sentinel loop. These are some names. If you want, you can remember. And gasless abdomen. So no air will be seen in the abdomen. No air will be seen in the bowel. That is called as gasless abdomen. These are some of the things which you may see on X-ray abdomen in acute pancreatitis. Colon cutoff, renal halo, sentinel loop, gasless abdomen. All right. Now come to management. How do you think you will manage acute pancreatitis? If it's mild, moderate, severe, what are you going to do? Tell him to stop alcohol, vagara. So it's very simple, the management of acute pancreatitis. If it is mild or moderate, you have to do nothing. You just tell him, stop alcohol, and you give him IV fluids if he's dehydrated, oxygen if need be, analgesia. बस. Okay, और कुछ नहीं देने की जरूरत है. No antibiotics needed. And if he can eat, you will let him eat also. एक दिन दो दिन में the inflammation will reduce and he'll be okay. So if he can take oral feeds, no problem. No need to keep him nil per oral or anything like that. If he has severe pancreatitis, means he has come with pancreatitis and organ failure. Some organ has failed. This patient has to be admitted in ICU. If he's having breathing problem, oxygen or endotracheal intubation may be needed. He may require, if he's having renal failure, he may require dialysis, vagara. So he will require some support. This patient will require IV antibiotics. He will require IV fluids. Typically, the IV fluid you will use will be ringalactate, or you can use normal saline. So he will require IV fluid. He will require oxygen so that the necrosis reduces. Oxygen will reduce the necrosis. Fluid will reduce the necrosis. After this, you will observe and see, is he improving? Observe for, is the renal failure getting better? Is the ARDS getting better? You observe. Two things can happen. Either he improves. If he improves, well and good. Or he doesn't improve or deteriorates. What does each scenario imply? Either he improves with antibiotics, IV fluids, or he deteriorates. CT मैंने कर दिया था पहले, but ठीक है. What does it imply? चलो, if he improves, then very good. Then you will start him on oral feeds. Then no need for any IV fluid, anything. Start him on orals, start him on oral antibiotics, discharge. If he deteriorates, what does it mean? Why is he not improving with antibiotics, IV fluids? Now he stopped alcohol, he's in the ICU, he may be intubated. Necrosis occurred does not mean anything. It means he is having infected necrosis or septicemia. So a patient who does not improve with conservative management is likely to be having infected necrosum or septicemia. तभी तो improve नहीं हो रहा, वरना improve हो जाता ना अभी तक IV fluid antibiotics से. In this case, you are going to do CCT to look for air in pancreatic necrosum, air specks. If you see air specks in the necrotizing pancreatitis, that means there is infected necrosum. And what do you do in this case? If there are air specks in pancreatic necrosum or pancreas looks to be infected, necrotizing pancreatitis with infection, aspiration, air specs. CT में दिखता है. You will see air inside the necrosum. You have to do. Now here you will call the surgeon. Everything till here, whatever you did was all medical, 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 medical. This is the only place where there is some surgery that has to be done. So the necrosum has to be removed. That is called as necrosectomy. Okay, this is the treatment of pancreatic necrosum, which is infected. What I'm trying to tell you is, if it is not infected, you don't need to remove it. It may go away by itself. You will have to remove it only if it is infected. So you will have to do necrosectomy. This can be done radiologically also. You can put a pigtail, or normally it requires surgery. Normally, because it's very difficult to remove it radiologically. So surgery is the treatment of choice for infected pancreatic necrosum. Okay, पहले बोलते थे debridement, now it is called necrosectomy. See, what you are doing here is treating the sepsis only, na? This is what you are doing here. So if he is not improving, then obviously you have to do something more drastic. So this is going to be the pathway of management of patients with acute pancreatitis. Absolutely clear it should be, and at no stage you should wonder. If you ever become a physician or a surgeon, this will go with you forever. Okay, beyond the scope of just solving MCQs. MCQs तो solve हो ही जाएंगे, पर आगे चल के भी मन में clarity आएगी कि pancreatitis में होता क्या है. 90% of general surgeons don't understand this. Okay, because that clarity of thought is not there. So many patients die because this is not understood. So they die in the ICU. And let me also tell you, even after necrosectomy, patients can die because it's not possible to remove all the necrosum. Yeah, it's not possible. If thoda bahut reh gaya, then it will continue to cause septicemia. Right? Don't they follow guidelines? ये सब guideline based नहीं है ना. So it's not a very easy disease to treat. That's what I'm trying to tell you. Why are you giving oxygen? Because the person may be having ARDS or pulmonary edema, SIRS, or your ARDS. All these complications can happen, organ failure. So if he's having ARDS, pulmonary edema, pleural effusion, for that you can give oxygen. Okay, answer this. This was a little tricky question. I think इसमें बच्चों ने recall भी ठीक से नहीं किया. I'm sure there is some problem in the recall. It can recur after removal, absolutely, because the rest of the pancreas can get inflamed again, whatever is left behind. Pancreatitis can lead to peritonitis, but very rarely. If the inflammation perforates the stomach or it perforates the colon. Okay. Patient presents with severe abdominal pain radiating to back. His amylase and lipase is elevated. Which of these should be avoided in the management? Okay. So let's see what you think about this. I am sure there is some recall problem in this, but I'll tell you how I frame the question from whatever recall I got. So firstly, they are telling you he is having acute pancreatitis, but they are not telling you is it mild, is it moderate or severe. वो तो नहीं बता रहे. Could be mild, could be moderate, could be severe. If it is severe, then for some time you can give NPO for some time, but you want to start him on oral feeds as early as possible. Parenteral nutrition may be preferred initially. This is a very controversial statement. I will say maybe. Till the ileus resolves. But yeah, 5% dextrose is not going to be the fluid. You are going to use balanced crystalloids like ringalactate or maybe normal saline. So definitely this is not the correct answer. But C is also not a correct statement. Okay, the preferred feed will not be parenteral. The preferred feed will still be enteral. Okay, it will still be enteral. You will still prefer nasogastric feed or nasojejunal feed versus TPN. So not the best choice, but between the two, go for B. Is what I gauged from the recall. Okay, no, dextrose will not harm, but understand I don't need only dextrose. I need sodium, potassium also, chloride also. So if I want sodium potassium chloride, normally I will get it in ringer lactate. No, just dextrose will give me only glucose. Why D is correct? Because I always want to start oral feeds. Oral feeds are the best feeds. You always go from oral to gastric feeds. I'm telling you preferential order to jejunal feeds. And last is going to be TPN in real life. This is how a surgeon will prefer initiation of feeds. If any one of you has undergone a GI surgery, laparoscopy, laparotomy, lap appendix, lap hernia, किसी का तो हुआ होगा. Did they keep you fasting for 4-5 days? No. They wanted you to start feeding as early as possible within same day, next day. They didn't give you TPN ना for 4-5 days. चलो आराम से करेंगे. नहीं किया होगा ऐसे. So yeah, the best answer is always going to be oral in life, and TPN will always be the last. That's why I'm not very happy with the option C. I don't feel this is also correct because it's not preferred. It may be preferred. Chalo, granted. Say Mandavi, something like that. Okay, it's a negotiation of an answer. TPN के बहुत कॉम्प्लिकेशन है पर वो हम करेंगे अगले के अगले 5th सेशन में करेंगे हम TPN. ओके, अभी नहीं करेंगे. अभी हम बेसिक जनरल सर्जरी के आज को टॉपिक करेंगे और फिर टीपीएन वगैरह बात के लिए रखेंगे. Does pancreatitis affects insulin level? Chronic pancreatitis will affect insulin level because pancreas produces insulin. In chronic pancreatitis, pancreas is damaged, so insulin production falls. So chronic pancreatitis will lead to diabetes-like picture. Okay. So now let's do some easy things in life. So that is your hepatopancreatobiliary. हाँ, कल ऑफ है, कल नहीं है ना, कल ब्रेक डे है. टुमारो इज द ब्रेक डे एंड देन बाकी के क्लासेस विल बी Wednesday, Thursday, 2 more days. So we have to do trauma, some general surgery, urology, breast endocrine. ये बाकी है, बाकी के दिन के लिए. एंड सैटरडे यू हैव END. तो जो छोटे मोटे चीज रह जाएंगे वो END में करेंगे, है ना. तो वैसा है. I can take, but they want a break, so they take a break. They have scheduled it like that. But don't worry, we'll manage. Whatever has to be pushed, we can do it on END. Whatever is needed to be covered. Okay, so don't worry about it. So we are left with urology, trauma, breast endocrine, and general surgery topics. So we'll do some general surgery topics today. So please find it where it is in the RR notes if you're using that. We'll do oral cavity and salivary glands. ये आज करेंगे. छोटे-छोटे topic है, हो जाएंगे आराम से. So first thing is about oral cancer. Now oral cancer, as you know, it is one of the most common cancers in men in India. Okay, apart from prostate, this is one of the commonest cancers in Indian men. Now it is increasing in women also. Why do you get oral cancer? Same, cooking, spirits, what you see, Mukesh, Rahul Dravid, same thing. So everybody knows why you get oral cancer. But more importantly, in oral cancer, there are some pre-malignant conditions. If you notice, हमने जो भी cancer किए हैं ना, GIT में सारे ऐसे ही करेंगे. We did risk factors, we did pre-malignant conditions. तो क्या है इसके pre-malignant conditions? इस पे question आते हैं. One is called leukoplakia. Leuko, you know, means white. Plakia means plaque or patch. So when I say leukoplakia, it's a white patch on oral mucosa, like tongue, cheek. It's a white patch on oral cavity mucosa. Now, what is unique about it? It cannot be removed. It can't be rubbed off. It will remain where it is. Okay, so it can't be rubbed off. It is asymptomatic, means it is just seen by chance, and it has no typical finding on biopsy. It has no typical finding on biopsy. It is a bit like metaplasia, like how you have Barrett's, a bit like that, but no specific finding on biopsy. So why are we worried about it? Why are you worried about it? Because like Barrett's, over time, it can undergo dysplasia. It can undergo dysplasia later. And this dysplasia will lead to which cancer? कौन सी कैंसर होगी ल्यूकोप्लेगिया से? प्री माइलिग्नेंट. कौन सी कैंसर होगी? वेरी गुड, एससीसी. ओरल कैविटी कैंसर विल बी स्क्वामस सेल. जो भी कैंसर हमने जीआईटी में किए थे ना, दे वर ऑल adenocarcinomas except esophagus. Everything, stomach, colon, rectum were all adenocarcinomas. This will be squamous cell carcinoma. Skin, oral cavity, penis, all those are squamous cell carcinomas. There is a variant of leukoplakia which is called speckled leukoplakia. This is the worst one. It has the highest malignancy risk. And the third one is called erythroplakia. Erythro means red. Plakia means plaque. Rest of the things are same. This also has a high malignancy risk. So between the three, if you want to go in increasing order of malignancy risk, it will be maximum will be speckled leukoplakia, followed by erythroplakia, followed by simple leukoplakia. Why does someone get any of these conditions? ये होते क्यों है? Leukoplakia, phakia. Why is it happening? So the same risk factors that cause cancer will also cause these conditions. Same, smoking, spirits, alcohol, तंबाकू, गुटखा, खैनी, जो भी आप लोग लेते हो, human papilloma virus, all of them cause the same. They will only cause any of these pre-malignant conditions. They will only cause squamous cell carcinoma. Now, how do they look? See this image. You can see this white patch here on the under surface of the tongue, leukoplakia. This image was asked once before. You see this thing on the tongue? What is this? Second image. It can be anywhere in the oral cavity. So this you are seeing, there are some white patches over here. In between it's all red. This is how you get speckled leukoplakia. It's a mix of leuko and erythro, दोनों का mixture. This is very malignant. Whatever is the condition, in any of these three conditions, what will be your first step or what will be the next step? The first step is going to be biopsy. And after biopsy, if there is dysplasia, you are going to remove them. You will do excision. ठीक है, आगे बात समझ लो. Biopsy, excise, and obviously the risk factor has to be eliminated. So you take biopsy and you excise it if it is showing dysplasia, just like you did Barrett's. Barrett's भी ऐसे ही किया था ना. No dysplasia, treat GERD. Low grade dysplasia, radiofrequency ablation, endoscopic mucosal resection. High grade dysplasia, treat like cancer. Same thing over here. The beauty of oncosurgery is the uniformity. आप कुछ भी oncosurgery में पढ़ो ना, it goes in the same sequence. You just need to know that sequence. हाँ, तो speckled is highest ना. This means greater than. Speckled is highest. यहाँ भी लिखा है मैंने highest risk. Okay. Now, when I get an oral cancer, now we talk about cancer. Usually, oral cancer will happen in India at the buccal mucosa. So, India में it is buccal mucosa. Worldwide it is tongue. These are the two common sites. Buccal mucosa in India. Worldwide it is tongue. And this cancer will just present simply with a growth. There will be a growth, an ulcer, non-healing, painless ulcer. Easy to diagnose. Patient will say, मुंह में जख्म है, देख लो. You will see it. It will look like a tumor. It will be a big ulcer, painless ulcer. It will look like a tumor. But very importantly, when you study the spread of the tumor, you should know about the neck nodes, because the tumor will spread to the nodes in the neck. Okay, this is the important part. This was also asked in entrance. I will show you what question was asked. This also they ask. Can leuko change to speckled? Yes, it can. Of course, Buco can change to speckle. So you need to know the levels of the neck nodes and their significance, as you see over here. So in the neck, you have level 1A, 1B. 1A means ये वाले जो chin के नीचे होते, they are called as submental nodes. And then you have 1B, ये वाले, they are called as submandibular nodes. So submental, submandibular. These are the first two groups of nodes. Then you have level 2, 3, 4, ये वाले, which are called as upper, middle, and lower deep cervical nodes. Upper, middle, and lower deep cervical. That is the name. Then you have this level 5, which are called as posterior triangle. And then you have level 6, which are in front over here, which are called centri, also called as Delphian nodes. This was asked in FMG. Level 6 nodes are also called as Delphian nodes. Easy question there. So you have these 6 levels of nodes. If I have a cancer, let's say in the lip or in the cheek, which of these nodes do you think will be affected first? Where will the cancer, to which node will it spread to first? 1A, 1B? Why? Why do you say 1A, 1B? What is the reason? Closer, absolutely right. What I'm trying to tell you is, or what I'm trying to ask you is, why are the levels given like this? 1A submental, 1B submandibular, 2, 3, 4. It's because if I get a cancer in the oral cavity, the first place it will spread to will usually be 1A or maybe 1B. First it will go there. From here, it will go to the node over here, 2. Then it will go to 3. Then it will go to 4. Then it will go to 5. That is the order in which the nodes will be involved. It's very unlikely that I have an oral cancer. Very unlikely. I have a cancer here. And only level 3 is involved. ये बीच के सारे spared है. ऐसा होगा नहीं. Skip नहीं होता. कभी कभी होता. Normally नहीं होता. So this determines that when I have an oral cancer, which neck nodes do I need to remove? Because it will always go in this order. That's why they are numbered like this. 1, 2, 3, 4, 5. That is the reason. That is the logic behind it. ये जो level 6 है ना, वो oral cancer में involved होते ही नहीं. Level 6 get involved in thyroid cancer. Or maybe in cancer of the larynx. तो अलग है. Simple है. Okay. So what nodes you are going to remove are based on this understanding. Right? So these are the neck nodes which are commonly involved in oral and oropharyngeal cancers. Understand this concept very clearly. It's not given like this anywhere in any book that you are going to read. Okay, so person can come with oral cavity mass. He can come with neck node metastasis. What are you going to do first? First, you have to confirm your diagnosis. So to confirm your diagnosis, you will do biopsy. Biopsy will tell you, yes, it is squamous cell carcinoma. Okay, biopsy will tell you it is squamous cell carcinoma. Now, once I know there is squamous cell carcinoma, I want to look for metastasis. To look for metastasis, I want to know how far it has spread in the oral cavity. What will I do? For local staging. Enough, now you know enough. Now you can use common sense. For local staging and for distant metastasis. Local and distant. Distant, though you know, will be PET scan. Local will be MRI. Okay, so MRI will tell me how much the tumor has spread. Has it gone into bone, into teeth? Are there neck nodes? ये सब मुझे MRI में दिख जाए. Soft tissue MRI. CT भी कर सकते हैं, but CT MRI में से एक चुनना हो, go for MRI over here. Okay. After I have this whole picture, and I have to decide the treatment. So treatment again will depend on the stage: early, advanced, metastatic. Early you will do surgery followed by chemo radio, Advance, you will first give chemo radio, downsize it, then do surgery. So that principle is the same. What surgery do I do for oral cancer depends on the location. Okay, so the surgery depends on the location, whether it is cheek, whether it is tongue, वगैरह वगैरह. जहां भी ट्यूमर है आपको एक ही चीज करनी है, आपको रिसेक्ट करना है विद अ मार्जिन दैट इज कॉल्ड एज वाइड लोकल excision. So wherever the tumor is, you have to do a wide local excision, and the margin that you need should be more than 1 centimeter. Okay, so you remove the tumor with a 1 centimeter margin. तो अगर cheek पे है करके निकाल दो, tongue पे है उतनी सारी tongue निकाल दो, buccal mucosa remove that much, floor of mouth. So wherever the tumor is, you need to do a wide excision. But apart from wide excision, you have to also remove the neck nodes. It should be radical, like how in stomach you did D2 lymphadenectomy. Same way over here, you have to do neck node clearance. So what neck nodes will you remove is the question. कौन से nodes निकालेंगे commonly? Wherever is the tumor, the first thing you have to do is you have to remove the tumor with a margin. So that margin will be 1 centimeter. Esophagus में margin क्या था? 10 centimeters. Stomach में margin क्या था? 5 centimeters. Colon में margin क्या था? Based on the vascularity. Rectum 5 centimeters proximal, 2 centimeters distal. Your margin 1 centimeter. यही तो है, ये तो सारे कैंसर का यही है मार्जिन चाहिए. But after removing the tumor, I have to remove the nodes. What nodes do I remove? That is based on the types of the neck dissections. Question can come on this. What are the types of neck dissections? The original neck dissection, the first one that was done, is called the radical neck dissection. Radical ND. ND means neck dissection. What did he say? What should you remove? Now you know the common sense. He said tumor can go to 1A, then 1B, then 2, 3, 4, 5. Remove all of them. So in radical neck dissection, you would remove lymph nodes 1 to 5. You would also remove, there is a gland over here, this one. You would also remove that gland, submandibular salivary gland. And after this, you would also remove 3 structures. One was this muscle, this nice big bulky muscle, sternocleidomastoid. You would also remove internal jugular vein, IJV. And you would remove spinal accessory nerve. See, the name only tells you it is radical. इतना सब निकाल रहे हो. 1 to 5 nodes क्यों निकाल रही हो तो समझ में आ गया, because that's where the cancer will spread. Submandibular gland comes in the vicinity of the nodes, so you have to remove it. But साथ में these 3 fancy structures also have to be removed. That was the radical neck dissection. But you know, over time, surgery has become less and less aggressive. They want to do lesser and lesser. So what they realized was, ये बहुत है भाई, थोड़ा कम करो. At least leave something in the neck, because if you remove this muscle ना SCM, तो neck ऐसे हो जाएगी, support चला जाएगा. Then came MRND, modified radical neck dissection. इसमें क्या करेंगे? इसमें आप सेम चीज करेंगे. You will remove lymph nodes 1 to 5. You will remove submandibular gland, but you will spare the other 3 structures. So all these are going to be spared. So you are going to spare sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve. They are going to be spared. So from radical to modified radical is this difference. ठीक है? This is the part 2 of the surgery. आज के जमाने में they do modified radical neck dissection. Yeah, tail of parotid is also removed. I think you are reading from the notes, but yeah, tail of parotid is also removed. Do you think anything else needs to be done after this? You removed part of the cheek. You removed all the nodes. और कुछ करना बच गया है क्या? ये इतना ठीक है, बस हो गया. अब रुक जा भाई. रेडियोथेरेपी तो पोस्ट ऑप. इंट्रॉप क्या करना है? बस हो गया. No, after this you have to fill in the gap. अगर आपने आधी टंग निकाल दी, पूरी टंग निकाल दी, या इतना चीक निकाल दिया, you have to fill that gap. To fill that gap, you will do some kind of a reconstruction. And this reconstruction is done with the help of what are called as flaps. Okay, these flaps we are going to do when we do plastic surgery. But just remember, oral cavity surgery will have three things: removal of tumor, removal of neck nodes, reconstruction. भैया आपने चीक निकाल दी, कुछ तो डालोगे ना वहां पर. You have to put something in place. You cannot just suture it back because it's a space. So you have to fill that gap. That is going to be some kind of a flap reconstruction. Okay, so that was about oral cavity cancer. Now another easy topic, that is salivary glands. How many salivary glands do we have? Three, 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 4, 5, 6, 800. Three on each side. Okay, okay, three pairs. Okay, no. Numerous. So there are two groups of glands. One are called major salivary glands. In major, you have parotid, your most favorite. You have submandibular, जो हमने अभी निकाला, the one that you just removed, submandibular, and you have sublingual. There are these three pairs. ये है parotid, ये वाला जो कान के थोड़ा नीचे होता है. This is parotid. जो चीक के नीचे होता है वो ये है submandibular. ऐसे जाता है. This is submandibular, like a mushroom. And tongue के नीचे, in the floor of your mouth, you have a third salivary gland, sublingual. And all of these glands are on both sides, left and right. So all of them are paired. So they are all paired salivary glands. And you have some minor salivary glands. How many minor salivary glands are there? More than 800 to 1000. So if anybody asks you how many salivary glands do we have, you should say 3 paired major and 800 minor. Okay, and not whatever. पहले 3 लिखा, फिर 4 लिखा, फिर 5 लिखा, फिर 6 लिखा, फिर न्यूमरस लिखा. ऐसे भेड़ंगे आंसर मत दो. 3 paired major and more than 800. ओके, 3 pair कहने का मतलब था सर, पर बोला नहीं ना अंकित. वो मेरे को ऐसा सी नहीं हुआ. If I would have grilled you a little more, I would have asked you, sublingual paired होती है क्या? Then you would have wondered, is it paired? Is it paired? And you would have said no. Then you would have said 5. I have done this enough number of times. That's why 806 plus. Okay, so these are the salivary glands, and in each of these glands, there is one unique disease that happens. In parotid, the most common disease that you get is pleomorphic adenoma, which we are going to study. You get pleomorphic adenoma. Most commonly in parotid. It can happen in any of these, typically seen in parotid. In submandibular gland, the disease you get are stones, very commonly, more than the other two glands. Submandibular gland में stone. इसमें क्या होता है? सबलिंगुअल में कौन सी यूनिक बीमारी होती है जो बाकी दो ग्लैंड्स में रेयरली होती है? It's very unique to sublingual salivary glands. Excellent, ranula. Okay, so remember, most common gland for pleomorphic adenoma, parotid. Most common gland for stones will be submandibular. Most common gland for ranula will be sublingual. That is the message. Now come to pleomorphic adenoma. Very easy disease, very interesting disease. Must know, came in this FMG. So what is this pleomorphic adenoma? It's also called as mixed salivary tumor. That is the other name. So it is called as a mixed salivary tumor. What is this tumor? It is a benign tumor. And it is typically going to be seen in parotid. It can happen in any other gland, but typically seen in parotid. Why is it called pleomorphic? Because it contains two components. It contains tumor of the gland. Tumor of the gland is called adenoma. And it also contains some tumor elements from the stroma. You know what is stroma, right? The part which is not producing anything, the supporting part. like it has myoepithelial elements. All this is seen in the tumor. Myoepithelial elements, myxoid elements, ऐसे बहुत सारे elements होते हैं. So it's a tumor which has gland also and other parts also. And it is typically going to be seen in the superficial lobe of parotid. What is the superficial lobe? What is superficial lobe? ये कहाँ से आ गई नई चीज? Above facial. तो जो parotid gland होती है ना, it's a bit like this. It has a big superficial lobe and then it has a small deep lobe. This is where the skin is. Okay, so when I feel it, I can feel this part, the superficial lobe. Deep lobe I can't feel. Deep lobe I have to put the finger in the mouth to feel. So most of the times the tumor comes over here in the superficial lobe, somewhere here. The difference between the superficial lobe and the deep lobe is there is a nerve that runs in between the two, like this, which will divide into its 5 branches. This nerve, of course, you should know, is going to be the facial. So facial nerve is what will separate superficial lobes and deep lobes. ये जो ट्यूमर होती है ना, ऐसी सिंपल ट्यूमर नहीं होती है. It has some ऐसे extensions. What are these extensions called of the tumor? What are these extensions of the pleomorphic adenoma? What are they called? They are called pseudopodia. These extensions. They are called as pseudo. Pseudo यानी नकली के. Podia यानी feet. So they नकली के पैर है. They are extensions. I'll tell you the significance of them later. If I get a tumor like this and it keeps growing, person will come with a swelling like this. So he will come with a swelling just in front of the ear, and when I examine the swelling, this swelling will lift the ear lobule. That's the very typical finding. It will lift the ear lobule. If you put your finger below your ear lobule, you can see the little groove here. You know, between your mastoid process and your jaw. यहाँ पर एक groove होती है. That is called retromandibular groove. This tumor will obliterate the groove. So it will obliterate the retromandibular groove. If you see any of these findings, it means it's a pleomorphic adenoma. It will obliterate the retromandibular groove. And it is mobile in this direction. आगे पीछे move होगा. So it shows mobility front and back. Mobility in anterior to posterior. What is this called? Anterior to posterior mobility. So it will only move ऐसे. It will not move ऊपर नीचे. खाली आगे पीछे जाएगा, ऊपर नीचे नहीं जाएगा. What goes आगे पीछे but not ऊपर नीचे? In your house, yeah. This is called as curtain sign. पर्दे की तरह वो सिर्फ आगे पीछे जाएगा ऐसे, ऊपर नीचे नहीं जाएगा. This is called as curtain sign. And because the tumor has so many parts, gland also, stroma also, mixed components, this tumor has a variable consistency. Means some parts will be soft, some parts will be firm, some parts will be hard. It will be variable. The consistency will be variable. Right? So person comes with a tumor like this. What are you going to do? What is the first step? Patient comes with a tumor like this. First step. You don't know it is pleomorphic adenoma. First thing you do, comes with a swelling in his neck. Biopsy, FNAC, USG. So remember, any head and neck swelling, anywhere in the head and neck, the first step will be USG. Because you want to know where is the swelling. Is it parotid? Or is it some artery there? It can be an aneurysm. Is it a lymph node? First step will always be USG. USG is the workhorse imaging for head and neck. So any head and neck disease you study, first you will do USG. Goiter, USG. Neck nodes, USG. Everything first USG. It is the workhorse imaging for head and neck. USG will tell you tumor is coming in parotid. Then the investigation of choice will be FNAC. FNAC will show you that it is an adenoma and it has pleomorphic elements. MRI is not needed in benign disease. If it's a cancer and I want to know how much it has spread, I will do MRI. But this is a benign disease. It has a malignant potential. How do you treat it? What is the treatment for pleomorphic adenoma? Do I have to remove it? That's the first question. Is it necessary to remove it? Or I can just leave it? Yes. Why? ऐसे सवाल पूछेंगे ना तो दिमाग चलेगा. Because you will face these patients in real life. So yes, have to remove because it is pre-malignant. And what is the treatment? The treatment is going to be what is called as superficial parotidectomy. So what you are going to do is called as superficial parotidectomy. Means what? I will remove the full superficial lobe. Ye pura ka pura. The whole thing has to be removed. So you will be like, but sir, this is a benign tumor. Why should I remove full superficial lobe? Why not just remove the tumor? That's because of the pseudopodia. If I just remove the tumor, there is a very high recurrence. So the treatment is going to be superficial parotidectomy to prevent recurrence. Any important complication, of this surgery? Next time they will ask this. What important complication can happen in superficial parotidectomy? Facial nerve can be damaged. Very good. Any other nerve can be damaged? Recurrence is not a complication per se, but yeah, there can be recurrence. So when they ask you complications, the most important complications are the nerves which can get injured. Like in hernia, you have nerve injury. Here also you have many nerve injuries. One of the nerves that can get injured is facial nerve or its branches. They very commonly get injured. Second nerve that can get injured is called auriculotemporal nerve. Auriculotemporal nerve. If this nerve gets injured, what will the person have? We've written it already. Auriculotemporal. Yeah, he will have Fraze syndrome. Fraze syndrome is also called as gustatory sweating. So whenever he eats food or whenever he even smells food, he will start sweating on his face. That is called as gustatory sweating or Fraze syndrome. It happens because of auriculotemporal nerve injury. Third nerve that can get injured is greater auricular. What happens if this gets injured? Greater auricular. Is there any big deal if greater auricular nerve is injured? या कुछ नहीं हुआ चलता है. So yeah, he will have anesthesia or loss of sensation in his cheek in the area of shaving. Anesthesia in area of shaving. So he'll say, जब मैं दाढ़ी करता हूँ ना मेरे को यहाँ sensation नहीं होता, मेरे को कान पे sensation नहीं होता. That is greater auricular nerve injury. It's not a very big deal. Okay. The bigger deals are facial nerve injury, obviously, then he'll have Bell's palsy-like features, or auriculotemporal nerve injury, which will lead to gustatory sweating. Okay. This question came. What is the answer to this? Before treatment for benign tumor. So this is going to be superficial parotidectomy. But let me also tell you, A can also be done. Wide local excision. Okay. This can also be done. It's given in Bailey. Which is why I feel even in this question the recall is not proper. दोनों option नहीं होने चाहिए. Because wide local excision is also done. Only that is not very commonly done, but it can very much be done. Okay. So definitely both of these are correct answers, but between the two, you go for superficial parotidectomy. Last two topics we are going to do because this came both in question and they are quite easy topics. These are abdominal wall defects which are present at birth. They are congenital. The first one that you see, this is called as gastroschisis. Okay, this is called as gastroschisis. Gastroschisis mein the intestines which are coming out from the abdominal wall defect, They are all exposed, they are uncovered. So you have exposed or bare or uncovered intestines. Where is this defect normally? Which part of the abdominal wall is having the defect normally? You can't see it in the image, obviously. Intestine is covering everything. So it is normally a defect on the right side of the umbilicus. Normally right parambilic. Normally. This defect is seen in teenage pregnancies. आज के ज़माने में इतना common नहीं है. But young mothers, when they deliver, this kind of a defect is seen. It's one of the common defects seen in teenage pregnancies, and it happens in isolation. Isolation means the child will not have other abnormalities. He will not have cardiac problems, renal problems. वो सब नहीं होंगे, सिर्फ ये होगा gastroschisis. And how do you treat it? Depending on how big the defect is, you have to reposit the contents and close the abdominal wall. So obviously the treatment is going to be surgical closure of abdominal wall, depending on how big the defect is. तो धीरे 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 उसको अंदर डाल दो और बंद करो. Obviously the child cannot survive with the intestines being exposed. कितना fast करोगे depends on how big. Small defect, you can straight away put it in and close it. Big defect, lot of contents, it may require 2-3 stages. All this is done under anesthesia. It's all surgery. Okay, all this is surgery. The second one is this. This is called as omphalocele, also called as exomphalus. The name itself should tell you where the problem is. Omphalo. Omphalos means umbilicus. So omphalocele means hernia from umbilicus. So here there is a defect at umbilicus. That is the name only. Na? There is a defect. It's like a hernia at umbilicus. And what you see here, you see intestines, but they are not bare. They have a covering. So the contents which are herniating are covered by peritoneum. Hernia covered by peritoneum. There are actually 3 layers, but what you see is the peritoneum. What is this? The white thing. So this question came in the exam. Na? So students said, sir, we thought it is a omphalocele with a cyst because they were pointing at this. What is this? Yeah, it is the umbilical cord. Absolutely. It is the umbilical cord. अभी umbilicus से क्या आएगा? Umbilical cord ही आएगा और क्या आएगा? So it is the umbilical cord. Basically, the contents are covered by peritoneum. This has many other associated diseases. So there are many other illnesses associated with cardiovascular defects, musculoskeletal abnormalities. So ये isolation में नहीं है. This is seen with other problems also. Child will have many problems. And this also you will do surgical repair. Obviously, इसको अंदर ही डालना है ना, अंदर डाल के बंद कर दोगे. That's how you're going to treat it. Simple. तो दोनों का इलाज ट्रीटमेंट ही है, सर्जरी ही है, और कोई इलाज है नहीं. दोनों ये क्वेश्चन आए थे, ओम्फालोसिल भी, एक्सोम्फालस भी. नहीं, नोट्स में CNS is a typo. It is CVS. You can change it in the notes. It is not CNS. It is CVS. It's a typo. वो मेरा उनको CVN जैसा लगा होगा, इसलिए उन्होंने CNS डाल दिया होगा गलती से. So you change that if it is there. Okay. So 2 questions came. Easy questions. I don't know the name of the repair. At least I don't know. So neonate is diagnosed with gastroschisis. Most appropriate management is going to be repair. Okay. Don't say wait and watch. Don't say accession. Slowly putting it inside is not the only thing you're going to do, right? You just don't put it inside. You have to put it inside and close. The best answer will be repair. Okay. Don't just put it inside. And this was the image. The umbilical वो है यार. Umbilical cord है. There is nothing like omphalocele with cyst. It's omphalocele only. This is only the answer. There is no omphalocele with cyst. ऐसा करके कुछ होता नहीं है. Umbilical hernia will have the skin covering. So there should be skin to cover it. That will be umbilical hernia. It will not be protruding like this. ठीक है? All the best, guys. See you.